All right, let's talk about limbic system. Limbic system. So it's a collection of neural structures which are involved in emotions, long-term memory, olfaction, behavior modulation, ANS functions. So all of these functions are through the limbic system. But more importantly, it consists of these all the things. So let's talk about that. So we have hippocampus, we have amygdala, mammillary bodies, anterior thalamic nuclei, cingulate gyrus, and entorhinal cortex. Entorhinal cortex, my bad. It is responsible for important things, 5 Fs: feeding, fleeing, flighting, and feeling, and sex. 5 Fs. Okay. Now, important thing is what you need to know is what is. So, two of these structures deal with the memory. So, let's highlight those. So, the two that deal with the memory are going to be the hippocampus. Where's my highlighter? Hippocampus and the second one, which is the mammillary bodies. These two deal with memory. Okay. And if someone has a lesion of any of this, then what's going to happen? Guess what? You will have amnesia. It could be interrograde, retrograde, or interrogate amnesia with any lesion on it. The other thing is for the cingulate gyrus. The important thing for cingulate gyrus is, which is yellow RNA. Let's look at that right here. Yellow RNA, right? And also look at the hippocampus, which is the red arrow in picture A. But it's gonna, it will show up next, maybe in some images. It will be clear in that. So for the cingulate gyrus, all limbic area sensation comes to the cingulate gyrus. All limbic area sensations will come here to the cingulate gyrus. Okay, now looking at the bottom part right here. So if you look here, you have feeding. So you have some sympathetic, and we said it's an ANS function, right? So fleeing and fighting are all sympathetic nervous system. Feeling, sex, all PNS, peripheral nervous system. Parasympathetic nervous system. Okay, so this is what the ANS functions are here. And that's all for this limbic system. So what is important here? Let's just highlight those parts. Limbic system, you got to know that, okay, they are for 5 Fs: feeding, fleeing, flighting, feeling, sex. And it is consist of hippocampus, amygdala, mammillary bodies, anterior thalamic nuclei, and cingulate gyrus. And the last one is the entorhinal cortex. Most important are hippocampus, amygdala, mammillary bodies. Okay. Let's look at the actual pathways for dopaminergic pathway. So dopamine comes from, let's look at this. So commonly altered, so these all dopaminergic pathways, they're commonly altered by drugs. For example, which drugs? High yield antipsychotic drugs, because they work on the D receptors, dopamine receptors, right? So they are going to alter the pathways of dopamine. So, and movement disorders. So antipsychotics are going to mess up the dopamine pathway, and the movement disorders will be there if something is altered, which are, for example, in Parkinson's disease, also messes up with these dopaminergic pathways. The mesocortical, so let's just take a look at these. There is the mesocortical, the mesolimbic pathways are involved in addiction behavior. So one of the mnemonics, actually, let's just read this first, and then I'll tell you the mnemonic, which is easy. But just imagine this. So meso, all are these meso ones are for addiction. Okay, so meso addict. You can call it meso addict. Meso is a guy who's just addict. Whatever you see, meso dopaminergic pathway, they are involved in addiction behavior. Okay, let's talk about the first one, which is mesocortical. as the name suggests, it's coming. Meso means ventral tegmental area. Meso means ventral tegmental area. Let's just call it that way. Cortical means, it's cortex, and limbic means it is going to go into the nucleus accumbens. Okay, so mesocortical, it's going to project from the ventral tegmental area to the prefrontal cortex. But let's just take a look at the picture, because otherwise it's not going to be easy to memorize this. So looking at this picture, look at the mesocortical. This is the mesocortical, which is starting from right here, from the ventral tegmental area, all the way to the cortex, prefrontal cortex. So that is the mesocortical, right? Look at the mesolimbic. Again, mesolimbic has to start from the ventral tegmentum, right? This area right here. So it's going to start here, and it is going to nucleus accumbens. So now let's talk about what are they doing. Now we know the anatomy now. What are they doing? So mesocortical and mesolimbic both are for motivation and reward. Motivation, reward. Okay. If you alter them, if you alter their activity, let's say you decrease the activity of the mesocortical, you're going to get negative symptoms. What are negative symptoms? For example, let me just write them here. For example, anergia, apathy, or lack of spontaneousness. Just remember apathy. All days apathy, anergia, and it's more in psych, so we will also do that. So, but these are all negative symptoms. So if you decrease the activity of this mesocortical, you are going to get negative symptoms. And I will summarize this in an easy way, but just right now we're trying to understand things. The mesocortical, on the other hand, this guy is, if you alter activity, for example, if you increase the activity of mesolimbic, you're going to get positive symptoms. And what are the positive symptoms? For example, the positive symptoms are like delusion, hallucinations, and they're all like, they're seen in where? Psych, which psych? Schizophrenia. Because in schizophrenia, you have increase in the activity of the mesolimbic pathway causing positive symptoms. But they also have a negative symptoms as well, but more positive symptoms. But that's another detail. Right now, we are focusing on the pathways themselves. So mesolimbic deal with positive symptoms, and mesocortical deal with negative symptoms. Okay, and they're all both doing motivation and reward, and they're both, because they're doing motivation and reward, they are addictive. So addiction occurs. Let's look at the notes. For the mesocortical, they're saying antipsychotics have limited effect on it. Okay, and mesolimbic, primary therapeutic target for antipsychotics. So the positive symptoms can be treated by antipsychotic, but the negative symptoms have a limited effect. Antipsychotics have a limited effect on the negative symptoms. That's a high yield point, but that's also in psych, so it will repeat. Now we're done with 2. Now let's look at the rest of 2. So now we got the nigrostriatal. Nigrostriatal are it goes from substantia nigra to the dorsal striatum. So let's take a look in the picture. Where is our nigrostriatal? So nigro goes from substantia nigra all the way to the dorsal part of the striatum. Okay, and what are they doing? So these guys, their function is, let's change color here. Their function is to motor control. They have a function of motor control. Okay, and they pronounce that nigrostriatal. Okay, you could do that if you wanted. But this is important. Just remember, substantia nigra, because it's nigrostriatal, so substantia nigra to dorsal striatum. Now, important thing is, if you alter its activity, what's going to happen is, if you decrease the nigrostriatal pathway activity, you are going to get something called EPS, extrapyramidal sign and symptoms. What are extrapyramidal sign and symptoms? For example, they are dystonia, akathisia, tardive dyskinesia, and Parkinsonism-like features, sign and symptoms, right? So these are all EPS, extrapyramidal symptoms. Uh, they are significantly affected by antipsychotics and in the Parkinson disease. Okay, that's for the nigrostriatal. The last one we have here is our tuberoinfundibular, right? Tuberoinfundibular is simple. It's from hypothalamus to pituitary. Let's take a look at the picture here. Tuberoinfundibular pathway that is coming from hypothalamus all the way to pituitary gland. So what is the function of tuberoinfundibular? Well, tuberoinfundibular, it regulates the prolactin secretion. When you decrease the activity in the tuberoinfundibular pathway, you are going to increase prolactin. Now, what's going to happen if you increase prolactin? That's also endocrine, but let's just call it here. When you increase prolactin, guess what's going to happen? You will have, let's just write it here. Increased prolactin is going to cause decrease in libido, sexual dysfunction. Importantly, galactorrhea and gynecomastia in males. Gynecomastia in males, in men. Okay, so it is significantly affected by antipsychotics. So let's summarize this. So we said everything here is significantly affected by antipsychotic except one, which was the first one, mesocortical. Everything else, because they have a limited effect. Everything else, they are affected by antipsychotics. Okay. Now, if you think about Parkinsonism, the one that is going to be out is going to be nigrostriatal pathway in the Parkinson disease. That's another add-on here. Okay. The first two, because they're meso means addict, for motivation, reward. Okay. The mesocortex is going to give you negative symptoms. Let's actually summarize this part here. And then mesocortical, negative symptoms. Mesolimbic, positive symptoms. Nigrostriatal, EPS symptoms, which is extrapyramidal sign symptoms. And tuberoinfundibular is going to give you increase in prolactin. Okay. So I guess that is all we have for this guy, for the dopaminergic pathways. Pretty easy, huh? Let's move on to the next then. Now we have, the next one is the cerebellum. Easy. Okay. But high yield. Cerebellum, it modulates movement. Okay. Important things. Function. Modulates movement. And muscle tone. It aids in coordination and balance. Aids in coordination and balance, right? Coordination of what? Coordination again of voluntary muscle activity and posture and balance. So all of these are, again, let me read it one more time. It modulates movement and muscle tone, aids in the coordination of voluntary muscle movement and the posture and balance. Okay, this is all done through cerebellum. Now, cerebellum has an so let's look at this thing. So it has an ipsilateral unconscious proprioceptor information, while inferior cerebellum peduncle from the spinal cord. So basically they're saying, if you look in this picture right here, they're saying that ipsilateral unconscious, meaning you don't know it's going there. Proprioception, you close eyes, you know how you're sitting, you know how your hands are. Every proprioception is there. Ipsilaterally, unconsciously, it's going. Information through the spinal cord goes into the inferior cerebellum peduncle, into the lateral cerebellum, which is all of this area, right? That's one thing that is going into the input to the cerebellum. The second one is your contralateral cortex. Again, sends to the middle cerebellum peduncle, again to the lateral cerebellum. These two are input. Okay. Um, and then you have one important feature here is going to be that these cerebellar inputs are by two sorts of fibers, by climbing fibers and mossy fibers. Inputs are two fibers versus output is going to be through the Purkinje cells. Okay. So now look at, so we till this point, what did we get? What did we learn? We learned, okay, we have proprioceptive information goes into unconscious ipsilateral proprioception and chondrolytic cortex sending into the lateral part of the cerebellum. That's all the input from the mossy fibers and the climbing fibers, so CNM fibers, right? These are all the inputs. Now we said here, the second point is deep nuclei, which are from lateral to medial. High yield point is dentate here. They're saying lateral to medial, just for one thing here, they're saying dentate is going to be the lateral nuclei. Lateral nuclei. And all these, which are emboliform, globose, and vestigial, they are all medial nuclei. Now the question might arise, which one is most medial? Well, the most medial is going to be the vestigial, right? This is most medial. Which one is most lateral? That's going to be the dentate nuclei, right? So we can just write these here. So for the picture purposes, you can understand what are we trying to say here. So we are saying the vestigial was the most medial, and then the rest will just follow. So vestigial, globose, emboliform, and the last lateral one was dentate. And dentate being the most lateral, vestigial being the most medial. Okay, and that is this point right here. Okay, they have a mnemonic, so whenever the first state has a mnemonic, that means that it is important. They don't write anything extra here, right? If they're writing a mnemonic here for just these nuclei, that means it is high yield. Okay, so what is the mnemonic? Don't eat greasy food. Again, D for dentate, E for emboliform, G for greasy means globose, and food for vestigial. Okay, and you know already which one is medial and which one is lateral. Now we have the medial cerebellum. Okay, so now looking at this picture here, we have, let's just take a look at this picture itself. What do we see? We see this color being the lateral cerebellum. So all of this is all lateral cerebellum. We have a medial cerebellum right here, right? And then we have the last thing, which is the flocculonodular lobe, right? This is going to be this lobe right here, okay, which is green color. Now we got that point. So now let's look at the pathology. So we have a medial cerebellum, which means, again, when we say medial cerebellum, what are we looking for? We're looking for this area right here. So medial cerebellum, which is the vermis. So in the medial part of the cerebellum is vermis. That's one thing. But on top of the vermis, we also have, we said, the medial or these nuclei. So we will say not only vermis, but we also have emboliform, globose, and vestigial. Actually, it would have been the other way around, which is vestigial being the most medial. Then you have the globose, then the emboliform, and then the dentate. So dentate is not going to be the medial cerebellum. So these all structures, they are going to control the axial and the proximal limb musculature bilaterally. Okay, what are they trying to say here? Because these are medial structures, so they will control the medial part, which is going to be your trunk. So it will be trunk and the proximal limb. Trunk and the proximal limb. So if they are doing the proximal limb, they have the control on the proximal. So who's controlling the distal limbs? Well, distal limb is controlled by the lateral cerebellum, right? Okay, that's an important thing. Distal limb. Okay, one more thing on top of this is, for example, if you have a lesion, if you get a lesion of the, let's just change color. If you get a lesion on the medial cerebellum, what's going to happen is that you will get the ataxia. Let's just write it here. You will get truncal ataxia, because it's the truncal ataxia, and proximal limb deficits and proximal limb problems. Yes? Same case scenario with the lateral cerebellum. What's going to happen is, if there is a problem, or there's infarction to it, what's going to happen is you have it's going to cause distal limb problem, and you will have one more thing where that is called dyssynergia, and I'll define that word. But dyssynergia. What is dyssynergia? Well, it's simplistically, it is that you will have intentional tremor, because it's a distal limb, right? So you will have tremors. Which sort of tremors? Intentional tremor. Intentional tremors, that's one thing. Intentional tremors is, again, what is intentional tremor? You can't get the hand to the target. If this is the target, you cannot get the hand to the target. Okay? If you say, okay, what is intentional versus resting tremor? Well, the resting tremor is seen in Parkinson's disease, in which you're resting, you're not going to in an action. You're not in action, but you still have the tremors. That's called resting tremor, and seen in the Parkinson's disease, which we'll talk about. But here, intentional tremor is when you are going to intentionally go towards an action, you will have tremors. That's called dyssynergia. That's one of the part of dyssynergia, which is the intentional tremor. Second thing you're gonna have is, through this dyssynergia, you will have that is going to be dysmetria. What is dysmetria? Dysmetria is basically loss of motor coordination. What is dysmetria? You have a loss of motor coordination. What is loss? What do you mean by loss of motor coordination? For example, you want to hit this point with, let's say you want to get your hand towards your nose, right? And then we will see in the test here. But the point is that you will have either the undershoot or overshoot of the intended movement. Okay, under or overshoot of the intended movement, and that is called the dysmetria. And the last thing with the lateral cerebellum disease that you're going to get is that is called dysdiadochokinesia. And what is this? Well, this is basically, you can't do rapid change of actions. So you will not be able to do rapid change of movements. So can't do rapid movements, alternating movements, not rapid just movement, but rapid alternating. For example, what is example? Flipping hands. Okay. So this is all about the lateral lesions. And one more thing is, for the lateral lesions, you can have them ipsilaterally. Ipsilateral problem. Okay, that's going to be an ipsilateral problem. Let's erase all this and now summarize this part. And actually read this part, which we didn't read. So lateral cerebellum, which is hemisphere. So the hemispheres are these cerebellar hemispheres. That's one thing. And also one more nuclei that we didn't put up top, right? That was the dentate, which is lateral. They all control the distal limb musculature ipsilaterally. So if you were to have an injury to it, you're going to have a injury to this thing will give you an ipsilateral problem. Okay. Now, what are the tests? Well, the tests are, again, we did talk about some of them, but here, rapid alternating movements. Rapid alternating movements are pronation, supination. You ask the patient to pronate, supinate. They will not. If they do it, great. If they're not able to do it, that's called dysdiadochokinesia. DYS. Dysdiadochokinesia. Okay. Finger to nose. And if that's like, again, overshoot, undershoot. And this is going to be seen in dysmetria. This, if they can't do it, it's called dysmetria. Heel to shin test. Gait to look for intention tremor. Okay. That is also there. Intention tremor. On top of this, you want to go for one more test, which is called Romberg test. Now, what is Romberg test? Well, the Romberg test is you ask the patient to stand, close eyes, and if they fall, then it is positive. And if they don't fall, that's great. So if the problem is the Romberg test is going to give you not the cerebellum problem. So that's very high yield actually. Romberg test, if it is positive, it shows that it's not a problem in cerebellum, it's a problem in the dorsal column. Dorsal column, and we will talk about that in the dorsal column, or somewhere it's gonna come up. But here the dorsal, if it isn't, so in cerebellar disease, Romberg test is going to be negative in the cerebellar diseases. Okay, what else we might have here? Okay, one last thing that is going to be, let me just erase this, changing color. Okay, that is about Purkinje cells. So there is a disease known as subacute cerebellar degeneration of the Purkinje cells. Subacute cerebellar degeneration of these Purkinje cells. And that is basically an autoimmune, let me just write here. This is an autoimmune disease, which could be also paraneoplastic, which is associated with some carcinomas, for example, small cell lung cancer, breast, ovarian, and uterine carcinomas. So what we have is specifically what you're going to see is, so it is associated with cancers, but what you will see in the serum is anti-YO or WHO and PQ antibodies, high yield. Okay, if you see this, you know that this is subacute degeneration of Purkinje cells, which is paraneoplastic associated with cancer or an autoimmune disease, which is just killing the Purkinje cells. Now, last point in all of this discussion for cerebellum, which is going to be that let's talk about simple functions. So what is the function of flocconodular lobe? We'll go from each one of these. So flocculonodular lobe, it is basically it takes from the inner ear. Inner ear, we have the vestibular nuclei, which sends the input into this flocconodular lobe, which goes into the vestibular nuclei again. But what it's doing is doing a balance and eye movement. It is for the balance and eye movement. So we did talk about how you have lateral cerebellar lesions, medial cerebellar lesions, and what they're going to do. But if you have a specific flocculonodular lobe problem, that is going to give you nystagmus plus vertigo and head tilting. Head will tilt. Okay, so nystagmus, vertigo, head tilting. This is all due to the fact that you have balance and eye movement, which is a normal function of the flocculonodular lobe. You knock this out, you are going to get the problem of nystagmus, vertigo, and head tilting, and that is for flocculonodular lobe. For the lateral cerebellum, Uh, let they're all doing the motor planning. Motor planning, they plan. So if they are planning, who's executing it? The execution is done by the medial cerebellum, which includes, remember, which includes vermis. Vermis is the medial part of the cerebellum. So motor execution. Okay. And that is all for the cerebellum. Yep. Let's move on to the next one. Now we have basal ganglia. Well, basal ganglia, it is important in voluntary movement again, and adjusting the posture. Look at picture A. This is all basal ganglia. These all structures are basal ganglia structures. It receives the cortical input, provides negative feedback to the cortex, and modulate the movement. So again, it's receiving the input from the cortex, provides the negative feedback to the cortex to modulate movement. And we will see how that is. Now, it has a structure known as striatum. Striatum includes putamen, which is the motor, and the quadrate nucleus, which is the cognitive. So looking at picture, actually, let's take a look at the structures first before we dive into the actual basal ganglia function. So the structures here are, so here is the third ventricle, right? Third ventricle, let me just erase this part. Try to get this one. Okay, this is third ventricle. And the fanning out of it on the two sides of it, that's the lateral ventricle. So just on side of it, below this, let's take a look at the quadrate nucleus. So lateral ventricle, just on side of it, it has the quadrate nucleus. So we said that striatum is the quadrate nucleus and putamen, right? So where's the putamen? Putamen is right here. So when you combine these two together, we call it striatum. Striatum, right? That's one thing. Now the second thing is looking at this big structure. This is thalamus. Below the thalamus is going to be, right here is going to be your hypothalamus, right? And then you have this two other structures. One is black. Black means Niagara. So substantia nigra, black. And you have this subthalamic nucleus, which is right above the substantia nigra. So we got all these structures. Now looking at this thalamus versus this lentiform nuclei, which is all of this structure, we have a part here which is just open, right? Which is white matter right here, open. That is the internal capsule. Okay, internal capsule. And the whole this structure is your lentiform nucleus, in which the first one is going to be your putamen. Then you have this globus pallidus, externus and internus. Okay, so E for externus and I for internus. You got the mammillary, two mammillary bodies sitting right there. And you have hippocampus and amygdala right there. Okay, so this is all the structure. Now looking here, we said striatum. Striatum is putamen and the quadrate. So quadrate and putamen is called striatum. And let's actually do this way. Right here, striatum. Okay. Lentiform nucleus includes putamen and globus pallidus, which includes externus and internus. Okay. Now, what is basal ganglia doing? It is important in voluntary movements and this adjusting posture. So how it does that is to do through direct and indirect pathways, which are very high yield. So let's take a look at these two pathways now. So we have a direct excitatory pathway and indirect inhibitory pathway. Excitatory basically means direct pathway is going to do what? Is going to, it wants you to do the movement. Okay, direct pathway will activate the motor cortex and to lead to the movement, right? Well, the inhibitory one is just going to inhibit the motor cortex, so you do not do the movement. You inhibit the movement, simple thing. Now let's look at how it's done. So the first thing that you want to know before this thing is that thalamus, which is this part right here. Thalamus wants to activate the motor cortex. Okay, it wants to activate. Okay, one more thing. These green lines are stimulatory versus the red lines are inhibitory. Now, stimulatory neurotransmitter is going to be your glutamate, and let me write actually. Stimulatory is going to be your glutamate, and inhibitory is going to be your GABA. So wherever they're going, if they're stimulatory, for example, this thalamus is going towards this motor cortex, you would just, by looking at the color, you already know that it's going to secrete glutamate. Well, here it's just going to secrete GABA. GABA is inhibitory. That means GPI is sending GABA to thalamus to inhibit thalamus, right? So this is important. Now let's look at the thing that I was talking about. So we said the thalamus. Now the first thing that you have to know is thalamus. It wants to have the movement. That's a part of thalamus. Thalamus wants to stimulate, send the glutamate to the motor cortex to activate the motor cortex, and this leads to movement. Okay, but at rest, it is inhibited by the GABA, which is released from GPI, is releasing GABA, one thing. And the other thing, which isn't mentioned much here, that's going to, you'll see some pictures somewhere, but that's going to be from this thing, substantia nigra. Wait, let me see, what is SCN? Yeah, substantia nigra. So substantia, wait, let's just go back. One more thing. Substantia nigra has two parts. Let's keep that here. Substantia nigra has two parts. The first part is going to be the pars compacta. So see, you have two things. One is stimulatory, one is inhibitory. They haven't mentioned, but here it's going to be your pars compacta, and the second one is going to be pars reticularis. So this is neuroanatomy, right? So we have to know the details. We have to know neuroanatomy. Anatomy means details of structures. You got to know these, right? So substantia nigra has two parts, pars compacta and pars reticularis. So if you look at the pars compacta, right, it is sending this GABA. And look at the PR, which is the pars reticularis. It is sending this glutamate to the striatum, which is here maybe the putamen. But striatum as a major thing. So let's get back to what I was saying. I was saying here that the GPI is at rest. At rest. Thalamus is inhibited by two structures. Thalamus is inhibited by one, GPI sending GABA to thalamus, and that inhibits it. That's one thing. Second thing is pars compacta also sends in the GABA to inhibit thalamus. That's one thing. So let's go back to the thing that we were talking about. Okay. So we said here, so here's the direct and indirect pathway. So before that we said thalamus wants to do the movement, but at rest it is inhibited by GPI and plus pars reticularis of reticularis of the substantia nigra. Yes, how do you say it? SNC. Okay. Now we say, okay, now we want to now we were at rest at this point now, right? Now we want to create a movement. Now when we want to create a movement, what we're going to do is, first of all, we want to somehow, what we want to do is we want to inhibit this guy so that it does not inhibit thalamus, and thalamus leads to the stimulation of the motor cortex, and we go from there, right? So let's see what they are. And I will go through this as a summary, but just right now, understand what I'm trying to say here. Okay. So direct pathway, cortex input via glutamate stimulates GABA release from the striatum. So here's what we are doing. Cortex is going to release, green means glutamate, on the striatum, right? On the striatum. When this glutamate goes on the striatum then releases GABA. Striatum would release GABA. So look at this. That GABA is going to inhibit. Let me zoom in. GABA is going to inhibit what? GPI. Again, simple things. Get back here. What's the movement? What's going on in the direct pathway? Well, direct pathway is the motor cortex is stimulating striatum. It stimulated the striatum itself. Now, striatum is going to release GABA to inhibit GPI. Why? Because GPI was the one who was inhibiting the thalamus. So inhibition leads to stimulation, right? That's the word here. So so let's actually do it here. So striatum, so cortex leads to release of glutamate to striatum. Basically, that stimulates the striatum, right? Now, striatum is going to release GABA on GPI, which was doing what normally? So normally GPI was inhibiting thalamus, right? So when the GABA goes on the GPI, it leads to inhibition of the GPI. When the GPI gets inhibited, that leads to free thalamus. The free thalamus is going to do what? Well, that's going to do its thing, which is to stimulate the cortex. And that's going to do what? That's going to lead to movement. So this is all the direct pathway. Let's look at back one more time so you know what it is. So cortex releases glutamate on the striatum, basically stimulating striatum. Striatum will secrete the GABA on its GPI, which is globus pallidus internus. And when you secrete GABA, what is it? It's inhibitory. You're trying to inhibit GPI. And what was GPI doing normally? Well, GPI was normally inhibiting the thalamus, and thalamus was on check, inhibited by this GPI. So as soon as you inhibit this GPI, what's going to happen is you are just going to free your thalamus. When you free the thalamus, it's going to stimulate cortex. That leads to movement. That's all for the direct pathway. Let's look in the book now. So we said cortex input via glutamate would stimulate striatum. The GABA will release from the striatum, which inhibits GABA release from GPI, disinhibiting, which is known as activation of the thalamus, which leads to increase in motion. Okay. So if this is doing the the motion, the movement, what's the indirect pathway doing, the inhibitory pathway? Well, it's inhibiting the motion, inhibiting the movement. So let's talk about that now. Changing color here. Now, for the indirect pathway, the cortical input via glutamate. Again, the cortex is sending an excitatory neurotransmitter, glutamate, that again, where? Again to the striatum, and the striatum releases again the GABA. But in here, instead of it going to the GPI, this GABA inhibits the GABA release from GPE. So now you ask, what was GPE doing in the first place, right? So if you look here, GPE, let me change this color to this. Where's my, yeah, GPE, this guy right there. GPE is sending GABA, which is an inhibitor neurotransmitter, to STN, to the STN. Okay, and what is, so basically, and that STN is doing what? Well, STN is going to, which is, what is STN? Subthalamic nuclei, right here. STN is subthalamic nuclei. This subthalamic nuclei is stimulating GPI to inhibit. When you stimulate GPI, GPI is going to do, GPI's job is to send GABA to thalamus. Simple. That's the GPI job. What is GPI? Globus pallidus internus. What's his job? His job is to send GABA, which is an inhibitory neurotransmitter, to the thalamus, to inhibit thalamus. When you stimulate GPI, it's going to inhibit thalamus. Simple. So this guy, subthalamic nuclei, this guy's job is to stimulate GPI, so he keeps sending the inhibitory signal to thalamus. Okay, but what if this guy gets inhibited? Well, if you inhibit this guy, guess what? You're not stimulating GPI. When you're not stimulating GPI, the thalamus will be open, right? So what do we do? Let's read. Here we go. So GABA inhibits the GABA release from GPE, disinhibiting, activating the STN. STN input via glutamate stimulate the GABA release from the GPI, inhibiting thalamus, and leads to decrease in motion, right? So it's a simple thing. Let's just read one more time. Very simple, but I'll go a little slow, and so you can understand what I'm saying. Okay, let's just take a look. Changing color to the black. Okay, indirect pathway. Indirect pathway, motor cortex again sending glutamate to the striatum. Simple. Striatum from motor cortex is always glutamate, green thing, glutamate, right? Now here, what striatum is going to do is, striatum is again going to release GABA. You see the red, red is always GABA. In any case scenario, it's sending GABA. But the problem is, where it's sending is the main thing. So this time, it's going to send the GABA to what? To where? It's going to send GABA to GPE. What is GPE doing? Well, we'd already talked about what GPI was doing, and that was that it is inhibiting thalamus. So what is the job of GPE? Well, GPE is constantly sending inhibitory GABA to inhibit thalamus. My bad, not thalamus, but STN, which is subthalamic nucleus, right? So GPE job is, which is globus pallidus externus, its job is to send GABA to inhibit subthalamic nuclei. Now, when the motor cortex stimulates striatum and they want to inhibit a movement, what's going to happen is the striatum sends this GABA to the GPE. So GPE will get inhibited. When the GPE gets inhibited, there is gonna be no neurotransmitter GABA release from the GPE that would inhibit the STN. So there is no release of GABA from GPE to the STN that would freeze the STN. When you free the STN, which is subthalamic nuclei, what's the job of STN normally? Well, its job is just to stimulate GPI no matter what. It stimulates GPI. GPI, when it gets stimulated, it sends the GABA to thalamus. And when the GABA goes to the thalamus, it inhibits the thalamus. This is exactly what's written here. So again, let's read. in a slow manner. So we have a cortical input through the glutamate that stimulates the GABA release from the striatum. While we read, let's actually do this thing. Glutamate is here, striatum releasing GABA. Let's read the next point, which inhibits GABA release from GPE. So this GABA goes here, inhibits GPE. GABA release from GPE, right? Disinhibiting the STN. Disinhibition means activation of the STN. So this, when you do not inhibit STN, there's a you free the STN, which is subthalamic nuclei. STN inputs via glutamate. Now STN was normal job was to send the glutamate, which is green, to the GPI. Stimulates the input via glutamate, which stimulates the GABA, which stimulates GABA release from GPI. So GPI is just sending back the GABA to the thalamus, inhibiting the thalamus right there. You're inhibiting thalamus because you're sending GABA, leading to decrease in motion. I hope that's clear. Now the last point here is, that is the change color. Dopamine from the substantia nigra nigrostriatal pathway stimulates the direct pathway by binding the D1 and inhibit the indirect pathway by binding the D2 receptor, leading to increase in motion. Again, what is this? They're saying substantia nigra, which is right here. Let's say they have a zoomed in picture here. Input from the substantia nigra is to the dopamine, but dopamine there are two receptors, D1 and D2. Well, the D1 is the stimulatory, which is direct pathway for the stimulation of the movement, and D2, which would inhibit the movement. So all they're saying in the next point is the dopamine coming from the substantia nigra, it would stimulate the direct pathway by if it acts on the D1, and it would inhibit the indirect pathway if it binds to the D2 receptor. And when you inhibit the direct pathway, inhibition of the indirect pathway, which is like no movement, when you inhibit the no movement thing, you're going to cause the movement, so that's going to be increase in motion. But more important is the first and second part, which we talked about, is the direct and indirect pathway. Do we have anything extra here? That is, let's talk about a little bit extra things. And that is, let's see, where is this? And that is some diseases, right? So we have lesions. Let's talk about some lesions here. When there is the lesion of this guy, which is substantia nigra, a lesion of this guy is seen in where? Which disease? Parkinson disease. Subthalamic nuclei lesion is seen in hemiballismus. Hemiballismus causes subthalamic nuclei lesion, at least hemiballismus. Striatum, if you have a problem of your striatum, if you have an injury to the striatum, that will be due to the fact that the disease that will cause a striatum injury or striatum problem, that's the Huntington disease, and the Wilson's disease. Now, the Wilson not only causes the problem in the striatum, which is quadrate nucleus and the putamen, but on top of that, it also includes the GPI. And so all of these are just movement disorders, right? All of these are movement disorders messing up the basal ganglia, causing the movement problems. But this is all they're doing. If you know where they are, what the structure they're causing, you would know right away, okay, this is whatever the disease is. But these are all movement disorders. Okay, let's just revise the whole thing and move on to the next. Okay, basal ganglia. Well, basal ganglia is important for voluntary movement. So we have a direct pathway which stimulates movement, and indirect pathway which inhibits movement. So in the direct pathway, what we have, the motor cortex sends in the glutamate to the striatum, and striatum then what striatum does is it sends the GABA to GPI. The normal jobs, let's talk about the normal job of GPI. Normally, the GPI is inhibiting thalamus by sending GABA. Normal job of GPE is to send again that same GABA to STN, which inhibits it. Normal job of STN, which is subthalamic nuclei, is to send glutamate to the GPI, which stimulates it. And GPI, you already know that part right there, that GPI is just going to inhibit the thalamus. Okay, this is all normal. One more thing normal is that thalamus, what's the thing of thalamus? Thalamus wants to stimulate the cortex, but at rest it is inhibited by GPI. This is all at rest and normal stuff. Now let's look at when we want to move when we want to have a movement, we go into a direct pathway in which we have glutamate from the motor cortex comes to striatum. Striatum sends GABA directly inhibiting the GPI, which when you inhibit GPI, you're not sending GABA to thalamus, and when it doesn't go to thalamus, the thalamus is free. When the thalamus is free, it leads to stimulation of the motor cortex and there is movement. That is direct pathway. Now, indirect pathway, on the other hand, is going to be again motor cortex stimulating the striatum through glutamate, right? And the striatum is going to send GABA indirectly, sending GABA to where GPI. So it's indirectly inhibiting the movement, right? First, it has to inhibit GPE. So when you inhibit the GPE by sending GABA, so GPE would not be sent. When you inhibit GPE will not be able to send GABA to the STN, so it would free the STN. The normal job of the STN was as soon as you get free, you're going to stimulate GPI. So it stimulates GPI, GPI stimulated, releases GABA, inhibits thalamus. This is all indirect. Dopamine has a D1 and D2 receptors. D1 receptors would facilitate the movement. And D2 receptors, indirect pathway, inhibit the movement. Okay. And looking at the structures here, important is this quadrate and putamen. They are all striatum. You have you have lateral ventricles, third ventricle. On top of this thing, it's also important. It is called the corpus callosum, and this is the only structure which connects the two halves of the brain. Corpus callosum. So see, this is one half, this is two half, but one thing which is going all the way from one side to another, that's called corpus callosum. Okay, and yep, that's going to be all for this thing. Okay, now let's talk about cerebral cortex regions. Cerebral cortex regions. Cerebral cortex regions we have, let's look at start from where? Let's just start from this area, premotor cortex. Premotor cortex. Just behind this premotor cortex, we have a primary, let's zoom in actually. So we have a primary motor cortex, and all of these things are in the frontal lobe. So what do we have in the frontal lobe? We have the premotor cortex, we have the primary motor, and we also have the frontal eye fields, the prefrontal cortex, and lastly we also have a Broca area. Okay, and then we have this division by the Sylvian fissure, which is right here all the way to the back, and we have the central sulcus, important central sulcus, which is dividing the frontal and the parietal lobe. So in front of the central sulcus, we have primary motor cortex, and behind the central sulcus, we have the primary somatosensory cortex. So let's talk about now the lesions here. So if we have a lesion of the frontal lobe itself, lesion of the frontal lobe. So first the question arises, what is frontal lobe involved in? Well, the frontal lobe is involved in personality of the person, personality, language, motor functions, and executive functions. What are executive functions? They are abstraction, for example, abstraction, planning, abstraction, planning, attention, impulse inhibition, important, impulse inhibition, and also working memory. Working memory. How can you test this abstraction or the frontal lobe lesion? Well, it could be tested simply by saying, okay, asking the patient, important, okay, ask the patient to describe two similarities between two objects. So ask a patient to define define the similarities between two objects. So define similarities between two objects. For example, you can ask the patient, okay, tell me the difference between a watch and a ruler. So a patient with a frontal lobe lesion will say they're both the same. And you ask how, they will say because they both have numbers. They are same because they both have numbers. The watch has numbers and the ruler has a number. So they both have numbers and they are the same. That's the frontal lobe lesion. Okay. Again, what do we talk about? We said the frontal lobe is involved in personality, language, motor function, executive function in which we have this abstraction that could be detected by asking the patient, tell us the difference between two objects actually, which is from, for example, watch and a ruler, and the patient will not be able to tell if they have a lesion. They will say they both are the same because they both have the numbers, and that will tell, okay, they have the frontal lobe lesion. On top of that, frontal lobe also does these also has this working memory inhibition of the impulse inhibition, high yield, working memory, high yield. Frontal lobe patient will not be able to have the working memory or impulse inhibition on top of all of that. Okay, let's look at the frontal eye field. Frontal eye field, it controls horizontal eye movements. So frontal eye field controls horizontal eye movements. Okay, so if you have a destruction of the frontal eye field, both of the eyes would deviate where? To the side of the lesion. So ipsilateral deviation of both eyes if you have a frontal eye field deficit or lesion. Let's look at the second thing here. We have the prefrontal cortex. The prefrontal cortex, if there is a lesion in the prefrontal cortex, it leads to disinhibition. One thing. Deficits in the concentration, disorientation of the patient, poor judgment. High yield is this re-emerging of the primitive reflexes. Primitive reflexes come back. You have a problem in the prefrontal cortex, or you can look for the prefrontal lobe. There's a lesion. Okay. Now, the last thing we have in this whole frontal lobe, we have the Broca. Let's talk about that. Broca area. Where are you at, man? Broca. area. Now this Broca area, it is basically the motor speech area. Broca is a motor speech area. Okay. It is always on the left hemisphere, which is the dominant hemisphere. It is involved in, what is Broca involved in? It is involved in speech production. It is involved in speech production, one thing, and not the comprehension of the speech, just the production of speech. Not comprehension of speech. It moves muscles for speech. So muscles, important, muscles. Why am I saying all these normal things? Why? Because when there's lesion in the Broca area, the muscles, it's called the broken mouth. That's the mnemonic. The broken mouth, the muscles are not working there. So the normal function is they move the muscles for speech, makes speech clear and fluent. That's the normal thing. So now let's talk about if you have a lesion of this Broca area. If you have a lesion, it's called expressive aphasia. Expressive aphasia basically means patient knows, expressive aphasia, patient knows what to say, but they will not be able to express it through the speech. So patient knows what to say, but they will not be able to express it. They will not be able to speak it out. So speech will be, now let me change color, putting here, speech will be broken speech. B for broken speech, B for Broca area lesion. Okay. Broken speech. Short, what is broken speech? Short sentences, stuttering, stops and starts. That's all broken speech. They start, stop, they stutter, they have short sentences. Okay. So that's what we have in the Broca area. Anything in the frontal lobe. So we did talk about all of them, I guess. Then let's take a look at one more thing here, which is central sulcus, right? Central sulcus, just behind this, like in the front of the central sulcus, that is called the precentral gyrus. There's a precentral gyrus here. Precentral gyrus. Now, important thing is what is sulcus and what is gyrus? Well, the gyrus are the ridges of the brain, gyri and sulci, right? So these are the ridges of brain, versus the sulcus are the spaces that are between the gyruses. So spaces between the gyri or gyrus. So precentral gyrus, mean this is going to be the ridge here, and here is going to be just behind the central sulcus. We're going to have a post-central. So easy, precentral and post-central gyrus. So why is that important? Because if you have a lesion, let's say in the precentral gyrus, it's going to cause contralateral convulsion, because this is the motor area, primary motor cortex, right? So convulsions. But if you have a post-central gyrus issue, because it is all sensory, it's the primary somatosensory area, it is going to, again, contralateral, because everything through the brain is contralateral, that's a simple thing, but it's going to give you sensory disturbances. What are the sensory disturbances? For example, numbness, paresthesias, all that, okay? So we are clear with that. Let's look at the parietal lobe now. Okay, now let's look at the parietal lobe. Parietal lobe has somatosensory area, somatosensory association cortex. Parietal lobe has one more thing is the arcuate fasciculus is also connecting. So if you look at it, connecting this Broca area to the Wernicke area. Okay, and Broca was motor, and the Wernicke area is sensory. And I'll talk about Wernicke and compare them together. But here, right now, what we are going to look at is the parietal lobe. If you have a damage, lesion to the parietal lobe, will cause spatial neglect. Spatial neglect. What is spatial neglect? You will have again contralateral, because it's a cerebral hemispheres. So you have a contralateral agnosia. What is agnosia? Well, agnosia is you will not be able to perceive objects or stimuli on the affected sites. For example, agnosia basically means you can't perceive objects or stimuli on the contralateral side. That's agnosia. You will have on the contralateral side, despite normal vision and somatosensation, which is somatosensory sensation. Okay, so that is one thing. Now another thing is you have just here, which is not drawn here, is something called, here it is. It is called angular gyrus. Angular. Again, what was gyrus? Gyrus was the ridges. Ridges, right? So angular gyrus, there was a ridge known as angular gyrus within the parietal lobe. Okay, that, if damage to the angular gyrus of the dominant parietal lobe, what is going to happen is high yield point is going to give you a syndrome known as Gertzmann syndrome. Okay, what is angular gyrus doing? Well, the angular gyrus job is to integrate the multisensory information to comprehend the visual, verbal, and tactile. This is all about sensations, right? So it is a multisensory information. It integrates multisensory information to comprehend the visual, verbal, tactile events and solve problems. It is important in reading comprehension. Okay, so this is the angular gyrus. So if you have a lesion of this angular gyrus, it's going to give you Gertzmann syndrome, and we will talk about that in the lesions later on. But now let's look at this temporal lobe. In the temporal lobe, what do we have? Temporal lobe, we have high yield vernix area, which is the sensory speech area. This was motor speech area. Okay, now vernix is in temporal lobe, right? But on top of that, we also have a limb association area in the temporal lobe, and the primary auditory cortex is also in the temporal lobe. Okay, so let's talk about, if you have, what is vernix area? Well, vernix area, it is present on the dominant hemisphere, usually the left side. So we know it's going to be present on the dominant hemisphere, and dominant usually is going to be the left hemisphere. It is involved in speech comprehension, but not the production. Okay, it is involved, let me just write, it is involved in speech comprehension, but not the production. So this is doing the comprehension, okay, but not the production. Okay, so if you have a destruction, now important point is, if you have a destruction of this vernix area, it is termed as fluent aphasia. Fluent aphasia. Excuse me. Fluent aphasia. What is fluent aphasia? It is fluent. The patient is fluent, but the patient is meaningless. The patient is saying all gibberish. You don't understand nothing. It's just fluent, but you don't understand. But meaningless. Fluent. There's no meaning to it. Okay, so that is seen in the vernix area. So comparing the vernix area, lesion of the vernix with the Broca area, and Broca area is the again the motor speech area, and the vernix is the sensory. Comparing to the speech part, the Broca patient, these are called as expressive aphasia, and the vernix is called as fluent aphasia. Now, speech and comprehension. So the vernix area, let's just change color. The vernix area lesion, the patient will be able to have a full potential of speaking. They will speak, but it's meaningless speech because they don't have any comprehension. So no comprehension. On the other hand, for the Broca area, which is expressive aphasia, in which that they want to express, they do what they know what to say, but they cannot say it. So there is no speech because it's broken mouth. They can't speak, but the comprehension, they know what they want to say. Okay, so simple. Broca, broken mouth, they can't speak, but they know what to say. On the other hand, vernix, their speech is way too much, fluent in speech, but meaningless. You don't know what they're saying. It's meaningless. Comprehension is nothing. No comprehension. Okay, and that is all for these two entities. Looking at the last few things here. The first is here we have this this guy, which is the auditory cortex. Auditory cortex is simple. I mean, it's if you have a lesion, it's gonna cause cortical deafness. Because as soon as you mess up the cortex here, you're gonna go. The terminology is called cortical cortex. Auditory cortex is out. Cortical deafness is that's what it's gonna cause. In which case, if you look at the patient, the inner ear works fine, but the patient can't perceive sound. And you examine, everything is fine. So that is the cortical deafness. Okay. Other areas of the temporal lobe which is not mentioned here are going to be olfactory bulb. Olfaction is all about smell, sense of smell. So if you have a destruction of the olfaction, you are going to cause ipsilateral anosmia, that you can't smell on the one side, ipsilateral side. That's one thing. Second thing is the Myers loop is also in the temporal lobe. Leading to the Myers loop is going to give you, and we will see that in ophthalmology, but this is going to give you a pie in the sky lesion. Pie in the sky lesion, which is basically, let me just draw it here, which is quadrantic nopia. Let me just draw it here so you know what I'm talking about. So here's two eyes, pie in the sky, right? So there's a pie in the sky. That's the Myers loop lesion in the temporal lobe. The last in the temporal lobe is the amygdala. Amygdala lesion. It is, first of all, it is important. What is amygdala important for? It is important for decision making, higher functions. Decision making, one thing. Higher functions. It is part of, we already talked about, it is part of a limbic system. Okay. Now, important thing is very high yield, that if you have a amygdala lesion, one more thing, it's a bilateral amygdala lesion will give you something known as Kluver-Bucy syndrome. Kluver-Bucy syndrome. Okay, and that is all for the temporal lobe. Now the last thing we have here on this is the occipital lobe, in which case we have the primary visual cortex. What is visual cortex doing? It processes the visual information from the contralateral homonymous visual field. So we will see that in ophthalmology, that the contralateral side goes into the visual cortex. So if you have a lesion, let's say, what it's going to cause is, if you have a lesion, it's going to cause, again, cortical blindness. Auditory was cortical deafness, and here's the cortical blindness. And that is all for this wonderful picture. So let's move on with the next, and that is all for the regions. High yield, very important. Moving on with this next thing is called cerebral perfusion. Cerebral perfusion. Cerebral perfusion relies on tight autoregulation. Primarily, it is driven by high yield, by PCO2, partial pressure of carbon dioxide, high yield. So this autoregulation in the cerebral perfusion, the brain blood is tightly autoregulated, but it does not depend on oxygen. Much more, primarily it is driven by the partial pressure of the carbon dioxide, PCO2. Well, the partial pressure of oxygen also modulates the perfusion in severe hypoxia, and we will talk about what is severe hypoxia. It also relies on the pressure gradient between the mean arterial pressure, MAP, and intracranial pressure, ICP. Decrease in blood pressure, for example, if you have decrease in blood pressure or you got the increase in ICP, is going to decrease the cerebral perfusion pressure with CPP. So in other words, we are saying when you decrease the blood pressure or you increase the intracranial pressure, that is going to cause decrease in cerebral perfusion pressure. That's one thing. Okay. The next thing is all about Cushing's triad. What is Cushing's triad? It is a triad of hypertension. So you got hypertension, HTN. You have bradycardia, low decrease HR, and you have respiratory depression. And the last thing is the respiratory. So low heart rate, low RR. So you can say HTN with low heart rate, with low RR, which is respiratory rate, which is respiratory depression. It is a triad which is known as Cushing's reflex. That Cushing's reflex is due to why? Because when you increase ICP, it causes Cushing's reflex, which is a triad. Okay. That's there. What else? Then lastly, you have on the right side, we have therapeutic hyperventilation. Leads to decrease in, when you hyperventilate, you're throwing out the carbon dioxide, right? When you throw out that carbon dioxide, your levels of the carbon dioxide within the blood will be low. So here's what they're saying. When they're low, it causes vasoconstriction. When it causes vasoconstriction, it decreases the cerebral blood flow. Okay, and that when you decrease cerebral blood flow, you're going to decrease the intracranial pressure. And when you decrease intracranial pressure, something will happen. We'll talk about that. But here, all due to the fact that you just gave someone a therapeutic hyperventilation, or either there's therapeutic hyperventilation or they're just hyperventilating for some reason, that's going to cause decrease in ICP. That is important. It may be used to treat acute cerebellar edema. Example, secondary to stroke. So stroke would cause cerebellar edema, and you can give therapeutic hyperventilation to decrease ICP that would treat the cerebellar edema. Okay, specifically that cerebellar edema which is unresponsive to other interventions. So CPP is the this guy right there, cerebral perfusion pressure equals MAP, mean arterial pressure, minus intracranial pressure. If CPP equals 0, there is no perfusion in the head. Cerebral perfusion is low. There is no perfusion, which causes brain death. What is brain death? Well, brain death is defined as coma, absent brain reflexes, apnea. 3 things. That's called brain death. Okay. Hypoxemia increases the CPP. Again, hypoxemia increases CCP only if PO2 is less than 50. And we talked about it right there, that if we have severe hypoxia, severe decrease in partial pressure of oxygen, which is less than 50, it is going to increase CPP, which is cerebral perfusion pressure. Cerebral perfusion pressure would increase. So one point is if you decrease PO2 to about less than 50, you are going to cause increase in cerebral perfusion pressure. And what was CPP? CPP equals the MAP, mean arterial pressure, minus the intracranial pressure. So you increase this, okay, it is increased by low oxygen, partial pressure of oxygen less than 50. CPP is directly proportional. Next line is CPP is directly proportional to PCO2 until the PCO2 is greater than 90. So let's take a look at this graph, which is whatever we read, it's explained in this graph. So here, it's simple. It causes, so if you look here at the by 50, let me just do this. So look at the partial pressure of oxygen. When it goes by 50, when it decreases by about 50, if you look here, what it causes is it's going to increase CPP, but CPP isn't here. MAP is here. One thing is MAP, and the other thing is ICP. So just remember, 50 is the threshold, which is severe hypoxia. Severe hypoxia less than 50. It's going to stimulate that autoregulation in the cerebral perfusion. One thing. Second thing is all about if the PaCO2 is about this, that if it is greater than 90, let's say this is 90. If it is greater than 90, CPP is directly proportional to CO2 until the PCO2 is greater than 90. So CPP will equal to about PO2 about 90, but after 90, it's just a plateau. It's a straight thing. So CPP doesn't increase. Okay. But important thing is just what is important in all of this is, let's just look at the important things. Important thing in all of this is the cerebral perfusion has a tight regulation on PCO2, 1 point. Second point is that it would also look at the hypoxia, which is low PO2 oxygen, when the oxygen level gets to a level of less than 50. That's important. Third thing is when you decrease blood pressure or when you increase the ICP intracranial pressure, you are causing decrease in CPP, which is cerebral perfusion pressure. But more important to that is this: when you increase ICP, intracranial pressure is increased, could be anything, right? That would cause cushion reflex, high yield. What is cushion reflex? It's a triad of HTN, hypertension, but 2 things are going to be low. One thing is heart rate, decrease in HR, and decrease in RR, which is respiratory rate. And that's the cushion reflex, which is the triad. Okay. Now, how that occurs, let's just write one more thing here. When you increase ICP, that's going to constrict the vessels, right? Increased ICP is going to constrict these vessels. Vasoconstriction will occur, leading to ischemia. That leads to increase in partial pressure of carbon dioxide to increase. When you increase this PCO2, and this is acid, when you increase the acid, you are going to decrease the pH. pH is going to decrease, acidic, right? And that decrease in pH leads to sympathetic drive stimulation. Sympathetic drive stimulation. And when you stimulate the sympathetic drive, that is going to cause what? Hypertension. But with hypertension, blood pressure goes high, it will go into reflex bradycardia. So here you go. So all of that is what? Is all about hypertension, reflex bradycardia, and low respiratory rate, which is respiratory depression. Okay, what else we might have? So let's compare these things versus what's going to happen in your cardiac tamponade, just to recall some of the cardiology here. So you have hypertension, but in cardiac tamponade you have hypotension, low blood pressure. Here you have low heart rate, there you have high heart rate. And the third thing is not respiratory, it is about JVD, which is jugular venous distension is there. But if you don't remember, that's fine. You'll see, but that you can look at that in the cardiology section. Now, one last thing all about this part here is knowing what PCO is. Well, PCO2, which is carbon dioxide, it leads to vasodilation of brain vessels, right? This is normal. So when you decrease the PCO2, it is going to cause vasoconstriction. When you cause vasoconstriction, you're decreasing the blood flow, decreasing ICP. Importantly, you can treat the edema if it is not treated by any other interventions. And that is all for cerebral perfusion. Now let's talk about homunculus. Homunculus. It's a topographic. So homunculus is a topographic representation of the motor and sensory area in the cerebral cortex. We have a motor homunculus, we have sensory homunculus. It is just a topographic representation of both. Topographic representation of motor and sensory part of the cerebral cortex. Distorted appearance is due to the certain body regions being more richly innervated and thus having increase in cortical representation. Right? So the more, like, look at the hand, look at the hand versus the whole leg or the feet. I mean, it's a very small area. Look at the face here. It has a greater innervation, richly innervated. The bigger the structure, the richly the innervated. Looking at the motor and the sensory. Right? So now let's just take a look at each one of them. An important thing here is while we're looking at homunculus, we have to also look at the ACA, anterior cerebral artery, MCA, middle cerebral artery, and PCA, posterior cerebral artery. So looking at these areas are also important. Importante, right? Okay. So now we have this. Let's look at motor. The motor, just looking at motor and sensory, you have ankle, toes, knees, hip, trunk. On top of it here in the sensory is the genitalia, which is extra. On top is almost the same. But here in the MCA region, which is the max. If you look, this is the biggest region here, right? MCA. So MCA, shoulder, elbow, wrist, hand, look at the hand. It has a pretty good richly innervated areas. Face, wow. In which case you have all of this: brow, eyelid, lips, jaw, tongue, and swallowing. Okay. So one thing is the hand is for gripping, face is for speaking, whistling, and swallowing is there. So gripping, whistling, speaking, swallowing, MCA. On the other hand, the sensory one, again, it's all about head, neck, and everything. Again, sensation, a lot of sensation on the hand and a lot of sensation on the face. Eyes, nose, face, upper lip, lower lip, teeth, gums, and intra-abdominal pharynx. Okay, and this one is going to be the PCA. So now let's talk about important thing here. We said the ACA, MCA, and all that, right? So let's take a look at each one of them. So ACA, let me erase this part. ACA supplies, we said it supplies, if you look here, it supplies two structures here. It supplies the lower limbs. So we're talking about ACA. It supplies lower limbs and the frontal lobe. Right? And if you have, and remember, what was frontal lobe about? It was about personality, thoughts, and behavior, and also the primitive reflexes. So if you have a lesion, of this, of the ACA, it is going to give you got the bilateral lesion of ACA. It is going to present with personality change, cognitive deficits, which is confusion. That's one thing. On top of that, you will also have urinary incontinence. And you will also have, so the mnemonic here is going to be, for the ACA, they can't kick you, so they pee on you. They can't kick you. And why can't they kick you? Because it's a lower limb. Everything lower limb is out. Genitalia is also out, causing urinary incontinence. I mean, urinary incontinence due to the frontal lobe. But here, they can't kick you. The mnemonic is they can't kick you, so they pee on you. Pee on you. That's a mnemonic for ACA. Okay. That is all for the ACA. But important point, I'm just going to write the important point here. That's the lower limb, LNL, lower limb, and frontal lobe. That's there. Now, the next thing is about MCA. MCA is going to give you, what is MCA supplying? First of all, the MCA is supplying the dominant lobe. If you have a lesion of MCA in the dominant lobe lesion, that is going to give you the brocaiphasia. That's one thing. And if it is non-dominant, it could be dominant, non-dominant, it's going to give you spatial neglect. And we did talk about both of them in just like 5 minutes ago. So you can look at that again. Now, one more thing on top of it is going to give you upper motor neuron lesion sign symptoms. Upper motor neuron lesion sign and symptoms. And contralateral. Now, the eye is also, look, the eyes are also there, right? Eyes. So eyes are also going to be affected here. So it will give you heminomus heminopsia with macular involvement. That's important. So you will have heminomus heminopsia with macular involvement. Why is this important? Because the PCA stroke is going to give the contralateral heminomus heminopsia, but with macular sparing. That is why the macula is important. Okay. And what is when I say macular sparing and macular and all that? Let me just draw it here so you know what I'm saying. So when you spare the macula, so the area affected is all of this, so the macula is spared. Oops. This is all on both eyes. Let's just draw this. Wait, why did I do that? I have no clue. Here's what is going to be there. So macula is spared. Macula is spared in the PCA stroke, versus macula is going to be involved in the MCA stroke, high yield. Now, on top of one more thing, the high yield point is, we said the this ACA was giving the lower limb more weakness in the lower limb or sensory loss in the lower limb than the upper limb. The MCA will give you the problem in the upper limb. It's all upper limb, right? Upper limb more than, greater than lower limb. Lower limb. Plus, on top of that, it will also give you phase deficit. Phase deficit, the whole phase deficit. So ACA was giving you urinary incontinence, the extra. Here, the phases deficit, that's the extra part. Plus the macular involvement in the homonymous hymenopsia for the MCA. For the last one, for the PCA, let's actually talk about quickly for the PCA. That PCA, we said it is macular sparing, that's one thing. Hymenopsia with macular sparing, one thing. On top of that, you also have sensory loss of limbs. Contralateral sensory loss of limbs, one thing. But also on top of that, you will have sensory loss of ipsilaterally, sensory loss of cranial nerve, ipsilateral sensory loss of phase 5, 9, 10 cranial nerves, because their nuclei are there. So we will talk about that as well. On top of that, you will also have, because of cerebellum there, we will also have limb ataxia. Okay, this is just an overview, by the way. More detail is going to be coming up, but this is easy right now, easy to understand through the picture, understanding what we are looking at, and when we do the actual strokes, it's going to be super easy, because you would know where the structures are, what is inhibited, and what is not inhibited. Last thing on this is going to be, they will ask something like max innervation. Which structure gets the max innervation? And that is going to be the thumb. Thumb has the max innervation greater than even the hand. So look at the thumb itself, how big of a thumb they have put in that picture. But one more thing is going to be, what is the minimum? So the max innervation and minimum. The minimum, the least innervation is to the, I'll let you answer that so we can move on to the next. Let me write it actually. Thighs. The least innervation is to the thigh. If you look at the thigh, where is thigh? You can't even see it. It's the ankle, the knee. Thigh is total out, the hip. The leg, the hip, thigh is total out. Thigh has the least, the max has the thumb, you know, have a fingerprint there. Okay, now let's move on to the next thing, which is called cerebral arteries and cortical distribution of these cerebral arteries. Looking at the green, we know this is ACA, MCA, PCA, right? All of that. So let's talk about the watershed zones. The watershed zone areas are high yield. Okay, so what it is basically there are 3 areas that are vulnerable. There are 3 areas that are vulnerable to hypoxia. Okay, let's take a look at that. So what we have is watershed zones are the cortical border zones occur between the anterior and middle cerebral artery. Anterior and middle cerebral artery and posterior and middle cerebral artery. Blue areas in A. So all we have is, this is your, if you look at this picture, it is right here. What do you have? You have ACA, you have MCA, and you have a PCA, right? So again, same thing here. ACA, ACA, and you have a PCA. Okay. So the cortical border zones that occur between the anterior and middle cerebral artery. So anterior and the middle cerebral artery, these cortical areas, and the MC and the PCA. So and the PCA and MCA are the cortical border zones. That's one thing. Then you have this internal border zone occurs between the superficial and deep vascular territories of the MCA, red areas in A. That's also important. That, okay, we talked about how the cortical borders are, which we mentioned this guy here, between A and MCA, and between PCA and MCA, right? But on top of that, we also are looking at the MCA, the deep structures, the deep vascular territories of the MCA, which are these. They are known as internal border zones. Between the superficial and the deep, they have the watershed areas, the watershed zones as well. And these areas are prone, they're vulnerable to ischemia due to hypoxia. Okay. So taking a look at it, the common location of the brain for brain metastasis. So these structures, these watershed zones are the common sites for brain mets. Infarct due to severe hyperperfusion would lead to AC and an MCA watershed infarct. For example, let me just draw it here. ACA and MCA, right? MCA. So right here, changing color for the better visualization. ACA, MCA. This area right here. What is going on? Right? AC and MCA watershed infarct, which is the proximal. It's going to give you proximal upper and lower extremity weakness. High yield is the man in the barrel syndrome. Man in the barrel syndrome. They have a weakness in where? In the proximal upper limb and the lower extremities. So they are the man in the barrel. For example, if you put a man in a barrel, what's going to happen? They will not be able to move. Same thing here. They have a weakness in the proximal upper and the lower extremity. They can't move. Calling man in the barrel syndrome. How easy that is. Simple neurology, right? No wonders. But moving on to the next one, which is PCA and MCA. This is PCA and this is MCA. Between the structure, there's the watershed infarct right there. It is going to give high order visual dysfunction because if you recall, it is visual cortex there. I mean, simple thing. It's going to cause visual dysfunction. Okay. Other than all of this, we also have, so we did talk about 2 structures here. I mean, 2 watershed zones. Let me just name them here. What cortical border and the internal border zones. The third one is going to be in the, that's also very high yield. That is going to be brain regions with high metabolic demand. With high metabolic demand. What are those areas? Well, that is hippocampus. Hippo is a big guy. He needs a lot of energy, and that's the high metabolic demand area. Hippocampus. Purkinje cells of the cerebellum. Purkinje cells of these cerebellum, because they're putting all that output from the cerebellum all the way. They only want one fibers, Purkinje fibers, so they are also in high metabolic demand. They need a lot of they need a lot of oxygen, these areas. So when you have a very slight area of hypoxia, these things are going to go into ischemia right away. Okay, so hippocampus, we talked about Purkinje cells of the cerebellum, and the third thing is the pyramidal neurons. Pyramidal neurons. So P's and H. Hippos. So the mnemonic is hippo. Hippo means hippocampus. Hippo is a big guy, needs a lot of energy, needs a lot of metabolic demand, with the two P's, with the pyramidal and the Purkinje cells. Okay, that is there. So we talked about 3 areas, and that's what we have. Now the last thing what we want to talk about in this section, that is that if you have sustained cerebral hypoperfusion, changing color here, sustained hypoperfusion. For example, when would you have sustained hypoperfusion? Cerebral hypoperfusion. That's in the hypotension, cardiogenic shock, cardiopulmonary arrest, anything with hyperperfusion, right? So that sustained hyperperfusion is going to give you global cerebral ischemia. What is global? What is that global cerebral ischemia? It is the infarction to all of these 3 vulnerable areas. Okay, and if watershed zone infarct, so one more thing. Lastly, the last thing is, if you have a specific watershed zone infarct, you're going to see in this picture as seen here, you have a symmetrical, bilateral, wedge-shaped infarcts. So if you zoom in here, symmetrical infarcts, you see wedge-shaped, bilateral, symmetrical infarcts for the watershed zone. The strips of necrosis. What is this? It's basically strips of necrosis. There's a necrosis over the cerebral convexity and parallel adjacent to the interhemispheric fissures. What all this is all about is that there's a necrosis which is seen as wedge-shaped for specifically watershed zone areas. Okay, and that is going to be all. So let's just summarize this one and move on to the next. Watershed zone areas, simple thing. There are 3 areas that can go into what? That can go into ischemia. They're vulnerable to hypoxia. If hypoxia occurs, the first thing that's going to go out could be any of these 3 things. So cortical border zone areas, anything border between the arteries, one thing. Second thing is from superficial and deep vascular territories of MCA. Okay, the third thing is you have the brain regions with high metabolic demand, which is hippocampus, Purkinje cells, and the pyramidal neurons. Okay, and if you have AC or MCA, this guy right here, AC and MCA stroke, you're going to have man in the barrel syndrome. If you have PCA and MCA, you are going to have infarct, which will give visual dysfunction, and not only visual dysfunction but also prosopagnosia. What is prosopagnosia? That is unable to recognize faces. unable to recognize faces, prosopagnosia. And that is all for the this watershed zone. One more thing is the Mets. Let's go to the watershed zones. Let's move on to the next. All right, here, circle of Willis. It is the system of anastomosis between anterior and the posterior blood supply to the big guy, brain, right? So now let's talk about the circle of Willis. Before we talk about circle of Willis, let's just mention here where the vertebral are coming from. So we have, let's actually zoom in to this part. So we have an arch of aorta, right? Arch of aorta coming from specifically the heart, right? So heart, arch of aorta. Arch of aorta gives rise to three major branches. The first one is called the brachiocephalic artery. And then the middle one is called the common carotid artery of the left side. So left common carotid artery. And the last one is the left subclavian artery. Okay. Now the first one we said, let's change color actually for better visual experiences. The brachiocephalic artery give rise to two branches. Let's just do it here. And those two branches are, the first one is again the right common carotid artery, and on the left side it is the right subclavian artery. Remember, left subclavian is there, and this is the right subclavian artery that is coming off from the BCA, which is the brachiocephalic artery. Now this right subclavian artery is going to give rise to two, let's change color, two more branches, and that is right subclavian artery giving rise to right axillary artery and the right vertebral artery. Well, it would have been the other way, but here, right vertebral artery. So that's how we get the right vertebral artery from, okay? On the other hand, the left vertebral artery is coming from the common carotid, give rise to internal carotid and the external carotid. Here, the internal carotid artery and the external carotid artery. That's the CCA, common carotid artery, give rise to these two. And the left subclavian gives rise to again two arteries. Left subclavian gives the first one, it gives the left vertebral artery. And it also gives the left axillary artery. So this is all the whole, how the everything coming from the heart and it goes up to the brain. So anterior circulation is all about, if you look at the Watershed, and anterior circulation is all about here. You have this all of these arteries going up with the common carotid, internal carotid, external carotid, and from the posterior circulation is the vertebral, right vertebral, and the left vertebral. So let's now get to the actual circle of Willis. Now the circle of Willis, so this right and left vertebral arteries, they come and they join, and when they join, it's called when they join, they form the basilar artery. One thing, basilar artery. Basilar artery is giving rise to the pontine arteries. Okay, and then these basilar arteries, they then divide, and they make the posterior cerebral arteries. Okay, and I'm just explaining right now. And after this, there's a nice mnemonic, not mnemonic, but a visual to it, and it will be easy to understand that. Okay, okay. One more thing, which I was talking about here, is the thing. Anterior circulation is all about what? Anterior cerebral artery, ICA and MCA. What was ICA? ICA is internal carotid, right? I guess yes, but we'll talk about that. I guess internal carotid right now. Yeah, MCA is the middle cerebral artery with the posterior circulation, and there is an anastomosis between all of this, and that's called the circle of Willis. Anastomosis means joining. Okay, so we were till here. The basilar was forming what two arteries? The on the left side PCA, on the right side PCA, posterior cerebral arteries. Now, posterior cerebral arteries, and they are going to join the middle cerebral artery via PCOM, posterior communicating artery. Okay, so we are now at the posterior communicating artery. Posterior communicating artery, there is also another artery that is arising from that. They're also joining into each other. That's called the internal carotid artery. I see internal carotid artery. Now, from the internal carotid, two arteries arise, and they are called the anterior cerebral arteries, and they also join together by anterior communicating artery, and this all forms the circle of Willis, which is the anastomosis between the anterior circulation and the posterior circulation and to the brain. And this was, I explained all of this here, the brachiocephalic, the subclavian, the aorta, CCA, ECA, VA, vertebral, and all of that. Okay, so now let's try to memorize stuff in a way which is easy. Now, since we understood this thing, let's take a look at this. So, easy way to know the circle of Willis is that we have vertebral arteries. Let's just do this thing. We have two vertebral arteries, right? So this is like a V, yeah, V vertebral, right? Let me actually make it. How do I make it? In a way which is no. Well, don't know much here. Anyways, here what we have is, let me do this. I have no clue. Okay, forget that. Let's just get a bold color, I guess. Yeah, right there. Okay. Okay, yeah, here. So we have a vertebral artery. Easy. This is going to be super easy, guys. We found a V, right? V is for vertebral artery. We found the V, vertebral artery. Vertebral artery, they combine and they form the basilar artery. The basal. The basal is like a plant, right? Basal plant, I guess. Basal plant, it has to be in a pot. So that pot is the pontine artery. Pot. So how are we gonna know it's in the pot? So let's just do this. So we have a B. So V is making a B, which is the basilar artery, which is a basal, and the basal seeds are in the pot. So pontine, and this is not my mnemonic. I've seen it somewhere. Credit to them. Okay, and then we got the basilar artery, and after that, we have posterior cerebral artery, right? So P is also coming on this side, P. So vertebral, basilar, and the P, posterior, P for here, here the P, and the PC is there, posterior cerebral artery. And then connecting these, all of them, to an eye. This guy, let's think about it as an eye. These are eyes. Eyes are for internal carotid. I for, don't call it E for eye, just call it I for eye. Okay, internal carotid artery is the eye, right? That eye has a ophthalmic branch, right? Which they haven't mentioned there, I guess, but it's going to give rise to an ophthalmic artery as well. Eye has a it has an eyebrow as well on top, so eyebrow is like an M. M is for middle cerebral artery, so I give rise to the middle cerebral artery, right? M. Let me do this. M. Okay, and the last point here is now this M. Then again, you have the last one, which is the anterior cerebral artery. So you make an A here. Again, A for anterior cerebral artery, and this A is connected by ACOM, which is anterior communicating artery. So in a nutshell, let me just again draw it in a quick manner so you know what it is. Vertebral artery, basilar artery, pontine artery, right? The pontine arteries. The posterior cerebral artery, the posterior cerebral artery. You have an eye for internal carotid arteries. Internal carotid artery, on top of eye, you also have what? You have a, which is the, what is it? Middle cerebral artery, right? So you have an eyebrow, which is a middle cerebral artery, right? It is connected by an A. A for anterior cerebral artery and A for a communicating artery. Okay, so this is all there. The extra things which are extra in the first aid that are your right here. You have the ICA, PICA, and SCA. The PICA comes from the vertebral arteries. The ICA is coming from the basilar artery, and the SCA is also coming from the basilar artery. And what else? We did talk about this, but also look in here for the middle cerebral artery, give rise to the lenticule-striate arteries, high yield. They supply the deep structure of the brain. And that's pretty much all. So if somebody says, okay, draw a circle of Willis, all you gotta do is V, B, pontine, posterior cerebellar, I in for the internal carotid, I M is like an eyebrow, so that's the middle cerebral. Then you have an A for anterior cerebral, and that connection is the ACOM. The extra thing is all about the PICA is coming from the vertebral, and ICA and SCA coming from the basilar. And that is all for the circle of Willis. Just one more thing to just know right now here is the ACA, A1, and A2, right? It's important to think about A1 and A2 is if you take a look, the A1 has a bilateral sort of supply. So if you knock this out, the other A1 will be able to give blood to the other region, right? Because there's a connection that is the ACOM. But here, after this point, the A2, right? So let me erase this point. A2, which does not have a communicating artery between this, so that A2, if you have an infarction, if you have an ischemia to the A2, so the thing goes like this: ACA, A1 infarction or lesion will give you less severe sign and symptoms versus ACA, A2 right here, right this, because there is no communication between it. So if you have a lesion in infarction, ischemia to ACA, A2 regions, they will give you severe sign and symptoms, as there is no collateral supply from the other side. So because there is no collateral supply, and that was the point I just wanted to add. Let's move on to the next one, which is dural venous sinuses. So dural venous sinuses, it's a large venous channels that run through the periosteal and meningeal layers of the dura mater. They drain blood from the cerebral veins. Arrow. Where's the arrow? Okay, is the arrow right there. And receive the CSF from the arachnoid granulations, empty into the jugular vein. So again, what are they trying to say? In simplistic word, they're saying, let me highlight it. These dural venous sinuses, they are large channels. They are large channels which run through the periosteum, periosteal and the meningeal layers of the dura mater. So they run in the dura mater, one thing. What do they do? What's the function of these dural venous sinuses? They drain the blood from the veins. Okay, arrows, they mean these arrows. Okay, I'll explain that. And they receive the CSF. Not only they drain the vein, but also they receive the CSF, which also they drain. They receive the CSF from the granulations, arachnoid granulations. They empty into the jugular venous, internal jugular vein. So let's take a look at these. So here's what we have. So we have superior sagittal sinus, which runs all the way. It is the main location of CSF return via arachnoid granulation. Okay, let's zoom in. Changing my color so you don't mess up. So here's the superior sagittal sinus. It is draining all the way to the confluence of sinuses, where all the sinuses are joining, which is sagittal sinus right here, and the which is formed by two other sinuses, which are inferior sagittal and great cerebral vein of Galen. They make this straight sinus. That straight sinus is draining into this confluence of sinuses, and we have occipital sinus and transverse sinus. So look at the flow, how the flow is all the way going towards sigmoid sinus, and from sigmoid to the jugular foramen, from jugular foramen into internal jugular vein. Okay, internal jugular vein. So this is all about how they are coming. They are sending all the CSF, not only the blood, the venous blood, but on top of that, all the CSF gets drained into the internal jugular vein. Okay, so now we have a pathology here, which is known as venous sinus thrombosis. Venous sinus thrombosis presents with signs and symptoms of increase in ICP. What are the signs and symptoms of ICP? Headache, seizures, papilledema, high yield, papilledema, ICP increase, papilledema, high yield. Focal neurological deficits may lead to venous hemorrhage. So again, you have a thrombosis of the venous sinus. It's going to cause what? Increase in ICP. And it's going to cause what? Venous hemorrhage, because there's a thrombosis. It's going to get hemorrhage associated with hypercoagulable. Why did you have thrombosis in the first place? Because you have hypercoagulable state, leads to thrombosis, causes increase in ICP, can burst out, lead to hemorrhage. Why you have hypercoagulable state? Question is that. Well, you have hypercoagulable state if you're taking OCP, pregnant, or the factor V laden. Okay, all of that causes hypercoagulable state. So let's just put it this way. You have a hypercoagulable state because pregnant and all that factor that gives the venous thrombosis, venous sinus thrombosis, that increases ICP. When you increase ICP, that causes all of this headache, seizures, focal neurologic deficit, papilledema, and it will burst out, causing hemorrhage. And that's what you have known as venous sinus thrombosis. Simple. Right? Exactly. Now, one extra thing that we would like to add here is about this beautiful cavernous sinus. Let's take a point here. Cavernous sinus, it is, if you have a look at the cavernous sinus, it says cavernous sinus it is bilaterally present between where? Between temporal and sphenoid bone. Between temporal and sphenoid bone. Okay, so the structure of this cavernous sinus anatomically is going to be like this, in which you have here's the running of, there is an internal carotid running there. You have some sympathetic fibers running here. It's called sympathetic fibers. And you have bunch of cranial nerves. You have 3, 4, CN3, CN4, and CN5. Of course, they're not anatomically. This is just to memorize these in an easy way. Okay, CN3, 4, and CN5, V1 and V2, not the V3. CN5, V1, V2, not the third branch of the trigeminal. Okay, CN5, V1, V2, and that's what we have. And you also have here cranial nerve 6. Easy to recall, right? Look at that. You have in coronal sinus, all you have is 3, 4, 5, V1, V2, and 6. This is all about coronal sinus and also internal carotid artery for sure. These are the structures that run in the coronal sinus. So if you have a coronal sinus problem, infection going into the coronal sinus or inflammation, that would mess up these all cranial nerves. But easy to recall because of the numbering 3, 4, 5, V1, V2, and 6. Okay, now add one more thing here that is going to be this thing called AV malformations. So great cerebral vein of Glenn enlargement. There's one other pathology that is called enlargement of the great cerebral vein of Galen or Glenn, however you want to call it. Enlargement is due to enlargement can occur if there is AV malformations. What is AV? Artery to vein malformation. Connection without the capillary. What is AV? Normally you have the artery, then you have the capillaries, and then you get the vein. But AV malformations, you don't have the capillary structure. When you don't have a capillary structure, you just have artery to straight to the vein. Artery straight to the vein. That's called AV malformation. Occurs in utero and may be asymptomatic until adolescence or adulthood. Can cause headache and seizures. So this great cerebral vein of Glenn can have a direct AV malformation, and the patient can present with headache and seizures. When you do take a look at, for example, on this on the MRI or something, you will see that, and that is due to the fact you have AV malformations, and the patient will present in adolescence or adult with headache and seizures due to AV malformation. That's pretty much all we have for dural venous sinus. So let's just recall the whole thing, move on to the next. So we said that dural venous sinus, a simple thing is that it drains cerebral veins plus CSF, which is coming from the arachnoid granulations, going all the way into internal jugular vein. Excuse me. Going all the way through internal jugular vein. Coronal sinus, it includes CN, cranial 3, 4, 5, V1, V2, and cranial 6, plus you have an internal carotid artery. There is a problem in the venous sinus thrombosis occurs if the patient is having a hypercoagulable state, pregnancy, OCP use, factor 5 latent causes thrombosis. That leads to increase in ICP, which causes headache, seizures, papilledema, high yield, neurological deficits. Well, thrombosis is going to cause hemorrhage. I know I have messed up pretty much the whole thing, but here's hemorrhage associated with the hypercoagulable state, and that's all. Let's move on to the next. What do we have here? Well, here we have the ventricular system. Ventricular system, let me change color. It's all about the ventricles, right? So looking at this picture, we have, where do we start? Lateral ventricles. So right there, lateral ventricles, there are two lateral ventricles on each side. lateral ventricles, lateral ventricle to third ventricle, the CSF goes from lateral to third via right and left interventricular foramen of Monro. Interventricular foramen of Monro. Okay, this is right here, which is right here. So from lateral ventricle, look at the shape of lateral ventricle. It's like C, but it also has a posterior horn, right? But there are two. Again, it connects from the lateral ventricle to the third ventricle. There's a connection. That connection is called interventricular foramen of Monro. From the third ventricle to the fourth ventricle, where's the fourth ventricle? Right here. Is the connection is called cerebral aqueduct of Sylvius. So third to fourth via cerebral aqueduct of Sylvius. Let's change in color. Interventricular foramen Monro, cerebral aqueduct of Sylvius. Now from fourth ventricle all the way to the subarachnoid space are two foramenas, meaning two openings. On the lateral side you have the Luschka. L for Luschka, L for lateral. On the medial side, you got the Magendie. M for medial, M for Magendie. Openings, aperture is meaning opening, right? So from here, from the fourth ventricle, where's fourth? Yeah, right here. Fourth ventricle, all the way to the subarachnoid space of the spinal cord is through these two foramens. Okay. And then after that, what's going to happen from the arachnoid space, from the subarachnoid space, subarachnoid spaces, we talked about just now that the CSF is going to go where? Arachnoid granulations. From arachnoid granulation is going to go where? We just talked about it. Venous sinuses. From venous sinuses is going to go where? Venous sinuses, specifically we're looking at sagittal, and it's going to go into the internal jugular vein. Okay, and that is what we have. Okay. Now, how is the CSF made? That's a question, right? Well, the CSF is made by the choroid plexus, high yield, located in the lateral, third, and fourth ventricles. So basically, all the ventricles, look, lateral, third, fourth, all ventricles make the CSF. What is choroid plexus made of? Specialized ependymal cells. Specialized ependymal cells. So CSF travels through the subarachnoid space via foramen of Luschka, Magendie, reabsorb arachnoid granulations, then drain into the dural venous sinuses, and then internal jugular vein. Right. Okay. And that's it. So let's just recall this whole thing and move on to the next. So we said from the lateral ventricle, the CSF is going to go through the interventricular foramen of Monro to the third ventricle. From third ventricle, we have the cerebral aqueduct of Sylvius that is going to drain the CSF from the third ventricle to the fourth ventricle. And from the fourth ventricle, we have two foramina, which are the two apertures. One is called lateral and one is medial. Lateral is Luschka, medial is Magendie. It's going to drain into subarachnoid spaces. From subarachnoid spaces, it is going to get reabsorbed by the arachnoid granulations, which would then drain into dural venous sinuses. From dural venous sinuses, it's going to drain all the way into internal jugular vein. And CSF is made by high yield point. It is made by the choroid plexus, which are specialized ependymal cells. Okay, of the choroid plexus. And that is all we have for ventricular system. Moving on with this brainstem. brainstem ventral view. Okay, nice. Brainstem ventral view. We have four. This is it's called the rule of fours. What are the rule of fours? Rule of fours. What is the rule of fours? It is the four cranial nerves are above pons. Where is pons? Well, the pons is right here. Okay, four are above pons. So if we take a look at the first one, look, what is that? Cranial nerve 1, 2, and 3, 4. Let me write this down. 1, 2, 3, 4, right? And this is, we said, is pons. This is all pons. So here, this thing is 4 cranial nerves are above pons. So this is pons. 4 are above pons. So 1, 2, 3, 4. Yeah, 4 above pons. Simple. Right. 4 exit the pons. Yeah. 1, 2, 3, 4 exit the pons. 4 are in the medulla. So after pons, what do we have? We have the medulla. This is medulla, right? And as you can see the coloring here, it is orange. It's medulla. The 4s are in medulla. So 1, 2, 3, 4. Yes. So the rule of 4 is all about 4 are above pons, 4 exit pons, and 4 are in medulla. That's only one thing. Now we have one more thing here that's important than this, which is, let's change color. It's about the blood supply. So we have some lateral and a medial. So we have a medial, and on the side we have the lateral nuclei, cranial nerve nuclei, right? So the lateral, let's just call this a lateral. Actually call the other guy lateral. Lateral, and call this medial. Okay. And it's gonna be all about, this is actually make it simple. Let me do this. So we have pons. We have, this is medulla, right? And we also have the top is called midbrain, right? But I'm not going to mention that, so just remember this. Pons and medulla. And here's the medial. Now there's another thing here. It's called medial, and this is lateral. So now let's take a look. We said so cranial nerve 3 and 4 are they arise from the medial part above pons. So look in here, 3, 4, and cranial nerve 5, 7, and 8. So 5, they're in lateral. 5, skip the 6, 7, and 8. And why skip the 6? Because 6 is in the medial part. And why is this important, medial and lateral? Because the blood supply. Blood supply is different, and I'll talk about that. And you have then the last, you have in the medulla, you have 9, 10, and 11. 9, 10, 11. And then 12 is again medial. Okay, so here's what we have. Let's now start writing down the blood supply. So this is medial part is supplied, medial part of midbrain, which is right here. It is supplied by the PCA. So I'm just going to write PCA. Lateral part of the pons is supplied by ICA. And the medial part of this pons is supplied by basilar artery. Basilar. And if this is ICA, the medulla is going to be pica. And this medial part of the medulla is going to be supplied by ASA. Okay, and why is that all important? Because if you just imagine you have an ICA, stroke of ICA, stroke of ICA will come with all of these as well. So cranial 5, 7, and 8 will be out, and you'll be thinking, hey, how? So this is all an anatomical structure. You have a medial part and a lateral part, because ICA supplies all of this. So if you have a stroke in ICA, it's going to present with this. If you have a stroke of pica, it's going to present with this. if you have a basilar artery, there's a thrombosis, whatever you call it, it's there, hemorrhage, anything, it's going to mess up the cranial 6. ASA will mess up 12. Same as PCA. PCA, posterior cerebral artery, will mess up your medial part 3 and 4, cranial nerve 3 and 4. So that's why it is important. And let's talk about also, since we are here, so let's also talk about some structures which are in medial and lateral. So remember, this is midbrain. So the medial structures, as the name suggests, is M, right? So there are some more medial structures. Lateral means side, right? They're on the side. When something is in the middle, it's called medial. When it's towards the lateral side, like on the side, we call it lateral. So there's a mnemonic to that. Some more medial structures are the medial structures that run in the medial part are your medial longitudinal fasciculus, your motor nuclei of the cranial nerves, your motor pathways. Which is motor pathway? Corticospinal tract. And what the last M is the one more track, which is called medial lemniscus, which is the dorsal column. So all these structures run medially, run in the middle. Okay, so the PCA, basilar, ACA, they also supply the middle part, all the middle structures. Okay, so if they have a lesion, they're gonna cause a lesion in all of these things. So again, medial longitudinal fasciculus, motor nuclei of cranial nerves, motor cortex, motor pathway, which is the corticospinal, and medial lemniscus, which is dorsal column. And we will talk about that in strokes majorly, but here is just a overview of things. On the lateral side, we also have a couple things, so let's just mention those. The lateral side is going to be, because it's a lateral side, this on the side, so everything is S. So here we're gonna have two tracks. One is the spino cerebellar pathway. Spinocerebellar pathway, one thing. The other one is spinothalamic pathway. And the other is sensory pathway of cranial nerve 5. And lastly, the fourth thing is the sympathetic pathway. So all the S's are on the side, while all the M's are medially. And that is all we have for the structures. If you have a lesion of these, one more thing, I know there's a lot of things here, but bear with me here. So the medial, if you have a medial lesion, you're going to cause, if you have a medial lesion, is going to cause medial motor sign and symptoms, M for motor sign symptoms. And for the lateral, it's going to cause sensory sign and symptoms for the cranial nerve nuclei, okay? And that is all for these things. Let me erase them and move on to the next part. Okay, now let's look at the brainstem, the dorsal view. So we did look at the brainstem, the ventral view, and the dorsal view now. Now, dorsal view has cerebellum removed. Okay, let's take a look at this. So here, what we have is, we have the thalamus, we have superior colliculus, inferior colliculus, superior cerebellopeduncle, middle cerebellopeduncle, inferior cerebellar peduncle. And cerebellum, remember, cerebellum is removed. And we have the medulla. Okay. So now let's talk about the first thing they're saying is the pineal gland. The pineal gland, oops, why is it zooming in? The pineal gland, it secretes melatonin and it regulates the circadian rhythm. The superior colliculus, it directs the eye movements to stimuli, to noise or movements, or the objects of interest. So what is it doing for superior colliculus? Directs the eye movements to the stimuli. Noise of movement, anything. Somebody calls you, you move right there. You see a bird, you look at it. That's the superior colliculus. Inferior colliculus, on the other hand, is all about auditory. Auditory, okay? And then you have superior cerebellar peduncle. These are all three peduncles for the cerebellum, and finally you get the medulla. Okay, your eyes are above your ears, and the superior colliculus visual is above the inferior colliculus auditory. Again, what the mnemonic is, your eyes are above the ears. So superior colliculus is above the inferior colliculus. Interesting. Why can't they say a simple thing? Superior means above. Superior is superior, right? Above, and inferior is below. Simple. Superior is above, inferior is below. Simple. And superior. Okay, actually, they wanted to get another mnemonic for that you are talking about. The one is auditory and one is eye movement. So they have one mnemonic for the two things. Yeah, you could do that. So eyes are above ears. Wait, eyes. Let's say these are eyes. Are above ears. Ears. Okay. Superior colliculus and inferior colliculus. Okay, makes sense. The next we have is about one thing is the superior colliculus. One more thing. If you have a lesion of the superior colliculus, the lesion of superior colliculus will give you perinod syndrome. What is perinod syndrome? Is the paralysis of the ventral conjugate gaze. So it's the paralysis of what? Vertical, which is known as upward, which is also known as vertical gaze. So you have a paralysis of that gaze. So what was the normal function of this guy? This guy was doing, superior colliculus is doing what? Conjugate vertical gaze. Conjugate vertical gaze. What is vertical? Vertical is upward gaze. So if you have a lesion here, if you knock that out, you're going to cause a perinod syndrome, which is paralysis of that upward vertical gaze. Simple, right? On top of that, you will also have absent pupillary reflex, impaired convergence, and Collier sign, which is bilateral upper eyelid restriction causing sclera will be seen. Stroke, hydrocephalus, pineloma. Okay, so all that was about was saying if you have a pineloma, you're going to increase the pineal gland so much that is going to compress the superior colliculus, that it's going to knock it out. When you knock it out, you're gonna have perinod syndrome, and perinod syndrome with the absent pupil, it's also going to cause absent pupillary reflex, impaired convergence of the eyes, and Collier sign. What is a Collier sign? That is the bilateral upper eyelid. So bilateral upper eyelid retraction. So it retracts upwards. When you retract, if you just retract, just think about it, if you retract the upper eyelid, what you're going to see is the sclera of the eye. So sclera of the eye will be seen without anything. And that is due to the fact that superior colliculus is out in the perinod syndrome. Okay. Alright, what do we have? Anything extra here? We did talk about the one thing extra here, that was the medial longitudinal fasciculus, right? We said that was the medial thing, medial longitudinal fasciculus. That medial longitudinal fasciculus has a cranial nerve in the middle, which were What were the cranial nerves in the midline structure? In the midline structure, we had a cranial nerves 3, 4, and 6. Remember? If you remember that, 3, 4, and 6, right? And those structures, that's the medial and also medial longitudinal fasciculus runs in the middle. So medial longitudinal fasciculus, 3, 4, 6, it has all the motor. This is just extra point, okay? It has just the motor nerves that connect each other for eye movement. So medial longitudinal fasciculus has 3, so C and 3, 4 and 6. So because if you recall, the mnemonic for all the nerve supply to the eye is what? LR6 SO4 O3, yeah? LR6 SO4 and O3. So lateral rectus cranial nerve 6, superior oblique cranial nerve 4, and all other is cranial nerve 3. So all of them, 3, 4, 6, are all in the middle through the medial longitudinal fasciculus. They move, they have the motor nerves, they're connected with each other for eye movement through the medial longitudinal fasciculus. So they have a simultaneous movement of the eye because they're connected to MLF, which is the medial longitudinal fasciculus. You knock the medial part out, you're going to knock this out. When you knock this out, you're going to knock out 3, 4, and 6. And that's, again, it's going to go in the discussion will be more in strokes part. Here, let's just review the whole thing, move on to next. We have the pineal gland just sits above the superior colliculus, and superior is all about the eyes, and the ears are low, so ears are supplied by the inferior colliculus. Pineloma would compress the superior colliculus, would lead to Perinaut syndrome, in which you will not be able to have a vertical gaze, which is the upward gaze, and also you will have impaired convergence and Collier sign, which is about you will see sclera of the patient because there's a retraction of the upper eyelid, and that is all in the for the brainstem. Now moving on to the next. Okay, now let's looking at the cranial nuclei. They are located in the tegmentum portion of the brainstem, between the dorsal and the ventral portions. So in the brain, so we have the midbrain, the pons, the medulla, and the spinal cord, right? So in the midbrain, we have the nuclei of 3 and 4. 3, 4. Again, the pons, we have 5, 6, 7, and 8. And in the medulla, we have 9, 10, 12. 9, 10, 12. And in the spinal cord, we have 11. So these are all the, we did talk about it already. You already know that these are the nuclei which are in the midbrain, coming from the pons and the medulla. But the new thing is here just the spinal cord, which is giving rise to the cranial nerve. 11. All right. Looking at this, we have the lateral nuclei, which we'd already talked about. Medial nuclei gives you the motor problem, if you have a lesion, of course. And the lateral nuclei are the sensory. So lateral nuclei are sensory, while the medials are motor. Okay? And we did talk about that as well. One extra thing that we would like to add here, that is that the lesions above the nucleus, if there's a lesion above nucleus of these cranial nerves, it will give the contralateral loss versus lesion below nucleus. That's not neutrophil, it's nucleus, okay? It's going to give ipsilateral loss. So above contralateral, below ipsilateral, okay? Now let's look at the vagal nuclei. Where is my eraser? Okay, vagal nuclei. In the vagal nuclei, what do we have? We have the vagal The first one is the nucleus tractus solitarius, NTS, nucleus ambiguus, and dorsal motor nucleus. Okay, so what is the function of NTS? Nucleus tractus solitarius. That is the visceral sensory information. For example, taste, the baroreceptors, the gut distension may play a role in the vomiting as well. The cranial nerves involved are 7, 9, and 10. Well, the nucleus ambiguus, or the motor innervation of the pharynx, larynx, upper esophagus, used in swallowing, elevation of the palate. The nuclear nerves involved here are the 9 and 10. Lastly, the dorsal motor nucleus, which sends the autonomic parasympathetic fibers to the heart, the lungs, the upper GI, to vagus nerve itself. So if you look, the common is all about here. Then you have here, and then you have here. Okay. So 3 nuclei: nucleus tractus solitarius, nucleus ambiguus, and dorsal motor nuclei. All are the vagal nuclei. And that is all for this one. Moving on with the next one is all about the brainstem cross sections. The brainstem cross sections are, so how's in the cross section, how the midbrain is going to look like. Well, the midbrain is, it has a superior colliculus, okay, at the level of the midbrain, and you have a cerebral aqueduct at the level of midbrain, cranial nerve 3, nucleus and its fibers, okay, and you also have on the lateral side you have cerebral peduncle, substantia nigra, red nucleus, and medial lemniscus. Okay, so here now how are we going to remember this as midbrain versus the pons and medulla? Well, to remember this as the midbrain, what we're going to say, we have we can call it an M. Okay, the structure for the M, okay, this is going to be the M here, and it has a cerebral aqueduct in the middle, so this is going to be the midbrain. Moving on to the next cross section, this is the pons. So for the pons, just remember that you have a P here all the way. Look, it's a proper P, and the P is from the middle. It has to be empty to call it P, right? So pons, in the middle you have the fourth ventricle. Just above the fourth ventricle you have the medial longitudinal fasciculus, and you also have medial lemniscus, all the M's on the medial side, and then you have on the side we have superior cerebral peduncle, locus coeruleus, and we have superior and also the middle cerebellar peduncle, and importantly cranial 5 is there, and corticospinal and corticobulbar, they also run in this. Corticospinal, corticobulbar were the lateral on the sides, right? Now the last one here we have the medulla. Medulla is also M, so because it's an M, there has to be an M here. But this is differentiated with the midbrain because this guy doesn't have any cerebral aqueduct and any sort of opening or ventricle thing. So medulla is a very closed thing in which we don't even have anything here. So that's how you differentiate medulla. If you look at medulla, we don't have anything in the middle. But if you look at the midbrain, which is also M, it has a cerebral aqueduct in the middle. What structures are in the medulla? We have the inferior cerebellar peduncle on the lateral side. We have medial longitudinal fasciculus, the lower portion of it, and nucleus ambiguus, inferior olivary nucleus, and the pyramids, medial lemniscus, and cranial nerve 10. And on top of that, you have all the nucleuses of vagus, the nucleus tractus solitarius, dorsal motor nucleus, and the nucleus ambiguus, right? And that's all for these cross sections. Just remember, M, recalling everything. If an M has, let me just erase all of this. If there is an M, it could be either medulla or the midbrain. The medulla does not have anything with the ventricle, while the midbrain will have cerebral aqueduct running here. That's the differentiation. With the pons, you already know it's a pons with the P. You can make a full P here. P for pons. And the pons has the fourth ventricle in the middle. And that is all for the brainstem cross sections. This is just an overview, right? So, I mean, it's going to be some more important details, but this is just an overview at the moment. Moving on with the cranial nerve and the vessel pathways. This is very high yield. What do we have? We have anterior fossa, anterior cranial fossa, the middle cranial fossa, and the posterior cranial fossa. And what nerves go through it, or what structures go through them. So for the anterior cranial fossa, we have the cribriform plate. What is running through it? The cranial nerve 1. CN1 runs through it. The middle cranial fossa has the optic canal and has the superior orbital fissure, and also has foramen rotundum, foramen ovale, and foramen spinosum. So what runs through it? From the optic canal, for sure the CN2 would run through that. Ophthalmic artery is an optic canal, so for sure it's going to run through it. On top of that, you have the superior orbital fissures, so CN3, the 4, and the 6. Let's just write them. 3, 4, 6 runs through it. Okay, and CN, now important point is about CN5. So CN5 V1 also runs through the superior orbital fissure, but foramen rotundum we have V2, foramen ovale we have V3. Foramen spinosum we have middle meningeal artery. So that's an easy way to remember, just one structures. It's not only artery, but it's also vein as well. Some extra things here, or that also run in the superior orbital fissure, are that the sympathetic fibers and superior ophthalmic vein. Superior ophthalmic vein and sympathetic fibers. Okay, they also run there. Now looking at the last one, that is the posterior cranial fossa. Here we have this internal auditory meatus, which has cranial nerve 5, 6, 7, and 8. CN7 and 8. And then you have the 9, 10, and 11. Jugular vein and 12. Okay, so auditory meatus 7 and 8. Jugular foramen 9, 10, 11, and jugular vein. Hypoglossal canal for the 12. Foramen magnum. Okay, the spinal cord, and the brainstem, spinal root of CN11. Remember 11, we said the nuclei are in the cranial, in the spinal cord. So spinal root of CN11, and vertebral arteries, they run through the foramen magnum. So all foramens, so now the mnemonic would be here that all foramens, so when we say foramen rotundum, ovale, and spinosum, all foramens are from middle cranial fossa except foramen magnum, which is posterior. So don't need to remember foramen magnum, because you already know it's the posterior, all the way posterior, right? So what you need to remember, if it's a foramen, if the name is foramen except the foramen magnum, it is going to be arising from middle cranial fossa to the sphenoid bone. Okay, that is there. One more important point is about ophthalmic artery. You also have a central retinal vein running from it. Central retinal vein runs through that. Okay, and now let's try to see how we can make it easy to memorize. Okay, one high yield point for this jugular foramen is this jugular foramen. If there is a lesion or tumor or trauma or infection which causes closure of the jugular foramen, it leads to Wernicke syndrome. Wernicke syndrome. And that Wernicke syndrome is basically, it is characterized by dysfunction of whatever structures are going through it. So what are the things that are going through it? Cranial 9, 10, 11, and jugular vein. So all these cranial nerve 9, 10, and 11 will be, there will be lesion on it because there's this, they're running through this foramen. Okay. Now the mnemonic that you could remember is, how do you know the first and, okay, here you go. Let's just change color. Yeah, actually do this. So here's the superior orbital, rotundum, ovale, and spinosum, right? So if you know this, if you know the optic canal, that's easy. That okay. Let's go from top. Cerebral frontale. You already know it's the olfactory nerve, CN1, and nothing more on that, right? It is the olfactory nerve. Then you have the optic canal. You know, optic canal is all about CN2 and ophthalmic artery and central retinal vein. Anything about retina, ophthalmic is going to go through of optic canal. That's easy. Now, important point is this one, which is superior orbital fissure. Superior orbital fissure. So you already knocked out your 1 and 2, and the left are 3, 4, 6, 3, 4, 5, and 6, right? So all 3, 4, 5, 6, 5 only V1, they run through superior orbital fissure. Superior orbital fissure. So the mnemonic is SRO. Let me just write this down. SRO. What is SRO? Study room only. Study room only. Study room only, the way you want to think about it as, okay, the top is the superior, so superior being having everything else. So you already know that, okay, CN1 is coming here, CN2 is coming there. The rest, 3, 4, 5, V1, and 6 will be coming from S, superior orbital fissure. So after 6, you're going to have the V2 and V3 part. So R is going to give the rise to cranial nerve 5 part 2, V2. And for the O, for the ovale, is going to be V3, right? So SRO. SRO. Spinosum, on the other hand, doesn't give rise to any cranial nerve, but also just give rise to, not give rise to, but the middle meningeal artery goes through it. So that's the opening, right? So a spinosum is going to have an opening for middle meningeal artery, will go through the foramen spinosum. So that's the mnemonic SRO. And then you have the internal auditory meatus. You know, it's auditory. So auditory is going to be about like 7, and just remember, you were till 6, so now we're left with what, 7 and 8, right? 7 and 8. It's just numbering, right? 7 and 8. That's the internal auditory meatus. Then you have the jugular foramen. Jugular foramen is going to give rise to, it's going to have an opening for 9, 10, and 11. And plus, because it's jugular, it's a jugular vein. Still, we are left with 12. So hypoglossal, because in the hypoglossal nerves, hypoglossal canal. No rocket science about it. Hypoglossal nerve canals is going to give an opening for 12. Foramen magnum, we already know, is going to give an opening for the spinal cord. But importantly, is which we don't think about normally, that's the spinal root cranial nerve 11. And the vertebral arteries for sure. And that is all for the cranial nerve and vessel pathway. Moving on to this thing, cranial nerve and arteries. Here, all we have is the arteries we talked about. So if you look here, you have this cranial nerve 1, olfactory nerve, cranial nerve 2. Midbrain is all about 2 nerves, 3 and 4, and pons. We did talk about it, but here is just a rereading this. In the pons, in the lateral side, in the medial side, in the lateral side, we have, what did we have in the lateral side? 5. 6 was in the medial. 7, remember, 5, 6, 7, 8. 5, 6, 7, 8. And for the medulla, we have only one medial was 12. So 8, 9, 10, 11. So 9, 10, and 11. And we did talk about this, what are medial structures and what are lateral structures of the cranial nerves. Now, importantly, we did also talk about the blood supply, but here, the PCA supplies the midbrain 3, 4. So midbrain, we have 3, 4. It was 3, 4, remember here. So it was all about PCA. And if you recall, basilar and AICA and PICA, and then anterior spinal. So this was anterior spinal, ASA. This was all about 9, 10, 11. All of these are from PICA and vertebral. And this here is the anterior, inferior cerebellar ICA. Medial is all about basilar, and lateral is labyrinthine. We did talk about it. This is just an overview again. So that's all for the cranial nerve and their arteries that they supply. Moving on with the actual thing here, we have the cranial nerve, very important. Now, cranial nerves, high yield, very important. So let's go through these. First cranial nerve we have is the olfactory nerve. Olfactory nerve is the smell. The function of the CN1 is smell. It's the only cranial nerve without thalamic relay or the cortex. We talked about how everything, sensations, all sensation go through thalamus. If you recall this structure that I had for the thalamus, right? Everything goes through thalamus except cranial nerve 1. And it doesn't have a relay on it, a relay on the thalamus. It is sensory, mnemonic is some, and this is the whole mnemonic for it. But so what if you didn't talk about one thing, which is if you have a lesion of the cranial nerve 1, what is going to happen is it's called anosmia. Anosmia. If you have a lesion of the damage, trauma, or skull fracture of the olfactory bulb, cribriform plate, anything, it's going to give anosmia. And anosmia is a loss of smell. Loss of smell. Okay. But on top of that, one high yield point here is, let's just add that point, that olfactory, although it's just about smell and everything, right? But also there is going to be loss of taste in these patients when they have when they get the lesion to the olfactory nerve, cranial nerve 1. And that is because the odorant, when the food, let's say food smell, binds the olfactory chemoreceptors, whose axons form the olfactory nerve rootlets. These then rootlet this synapse to the olfactory bulb by passing through the cribriform plate all the way to the ethmoid bone. Second order axon will project from the olfactory bulb to the primary olfactory center in the where high yield in the middle temporal lobe, or okay, and via the olfactory tract. Now, if you have a lesion here in the olfactory nerve, olfactory dysfunction occurs due to could be what are the reasons? It could be infection. So let's just erase this. Could be infection that would mess up the olfactory nerve. One thing is infection. Second thing is all about neurodegenerative diseases, like for example Alzheimer's, dementia. Third thing is head trauma. That is very important. Head trauma, direct trauma, and also deceleration forces, which lead to destruction of those cribriform plate rootlets, causing anosmia. And then anosmia, because we have the taste is also through 60% is through smell and 40% is the actual taste. So anosmia, because you can't smell that good food, smell, what's going to cause it, that it's going to lead to agousia. I don't know, agousia or something. Agousia is basically loss of taste. So what now? Just recalling this whole summary of this thing. If you have an olfactory nerve deficit problem, knock out your olfactory nerve CN1, you're not only going to cause anosmia, which is loss of smell, but also agousia, which is loss of taste. That is high yield. Okay. The second one is all about your optic nerve. Optic CN2 is the sight, right? And sight is not really a so CN2 is not a peripheral nerve. It is not a peripheral nerve. It is the outgrowth from the diencephalon. So the myelination, so it is the important thing is because an outgrowth of the diencephalon, if you recall what was diencephalon, so you had a telencephalon and you had a diencephalon, it's the outgrowth of diencephalon. So it's going to be, importantly, it's going to be myelinated by oligodendrocytes, myelinated by high yield oligodendrocytes. Okay, the pathway for this optic nerve is going to be optic canal of the sphenoid bone. It goes through the optic canal of the sphenoid bone. And we did talk about just now that it goes through that optic canal. Okay, and if you have a lesion, if you get the lesion on this optic nerve, what is going to happen is it's going to cause ipsilateral blindness. Maybe I can zoom out a little and write on the side. That would be easy to read. Okay, here's what I mean. It can lead to ipsilateral blindness. Okay, and that is all we have for optic nerve. Now moving on to the cranial nerve 3, which is oculomotor, so CN3. It is it has the function of eye movements. Okay, which is the SR, superior rectus, is going to move the eye to upward position. IR, which is inferior rectus, is going to move it inferiorly, downward. MR is the medial rectus, which is going to move it medially. And then you have this IO, which is what? Inferior oblique. Inferior oblique is going to cause, now this is important, inferior oblique and superior oblique, right? So inferior oblique is going to give the movement of superior rotation. Superior, although the name is inferior oblique, but it's going to give superior rotation movement. Superior rotation movement, okay? That's one thing. One thing, eye movement. On top of that, you have the pupillary constriction, which is sphincter pupillae. Through pupillary contraction, constriction through pupillary sphincter pupillae, and accommodation, high yield, which is through the ciliary muscle. Eyelid opening, which is levator palpebrae superioris muscle, remember? And that accommodation, now question is, accommodation is to the ciliary muscle, right? High yield. Pupillary constriction is to the sphincter pupillae, while eyelid opening is levator palpebrae superioris muscle. Okay. Now, if you get a lesion, now the question is, if you get a lesion of CN3, it's going to cause down and out eye movement. So down and out is like this. Down and out, high yield, down, out movement of the pupil. And on top of that, because it's also eye opening, it's applying eye opening, levator palpebrae, you can't provide that innervation now, so it's going to cause ptosis. That's one thing. And pupil will dilate because it causes constriction. So when you can't constrict, it's going to cause dilation of the pupil, and there will be no accommodation, right? Because you're leading to accommodation here. You can't accommodate, which is the ciliary muscle. You can't read in a close by when convergence is not going to happen. That's what you have. All right. Then you have the CN4. CN4 is all trochlear nerve. Well, the trochlear nerve is only supplying one eye muscle. That is SO, superior oblique. Well, superior oblique, what is the function of superior oblique? If inferior oblique was turning superior rotation, the superior oblique is going to turn the eye down and in. Superior oblique is doing what? Down and in. Inward movement of the eye. That's the superior oblique. It is used in, where do you use the superior oblique? Used in reading or stairs. When you're going on stairs, that the superior oblique is used. So if you knock this out, now if you knock out this CN4, what's going to happen is you knock out CN4 SO superior oblique muscle. That's going to cause because you can't move down and in. You're going to cause diplopia, or double vision. Now I would tilt outwards, because it was causing in medial convergence, right? But now, since you don't have that anymore, it's going to go outwards. right? So eye will tilt outward, head would tilt. Now to compensate, head would head tilt away from the lesion. Head would tilt away from lesion. Okay, that's it, like trochlear nerve palsy. You know, to compensate this. They can look down and in. They can now look down and in. That's simple, and they will not be able to read or go downstairs. They can't look down and in, and that's all about this trochlear nerve. Now, looking at the CN5, CN5 is trigeminal nerve, with couple branches, which I guess they haven't mentioned here, but let's just talk about them here. So we have a V1, V2, and V3. So here's the head. Here's, let's say, the nose. Okay, so all of this is going to be V1. From nose to almost the upper side of a lip, you have a V2, and then you have the mandibular V3. Let's take a look at what are the functions. Trigeminal nerve CN5 is going to give innervation to mastication muscles, facial sensations. Again, right here, there's facial sensations, which are your ophthalmic branch, maxillary, so V1, V2, and V3, which is mandibular divisions. Somatosensations from high yield somatosensation, anterior two-thirds of the tongue, dampening, again, dampening of the loud voices, again, high yield, through which tensor tympani, or tympani, tensor tympani, okay, dampening of the loud voices. So what are the functions? Mastication, facial sensations, anterior two-thirds sensations, and dampening of the loud noises through tensor tympani. Okay, it has both the sensory and the motor, and you can see this is all motor, this is all sensations, so it has both the sensory and the motor innervations. Now, important thing is that what if you get the a lesion of trigeminal nerve? Let's just talk about that. Changing color here. Trigeminal lesion will present with, first of all, because your facial sensations are there, so you will have a numb face, right? That's one thing. That's numb face, and deviation to the weak side. Weak jaw will have an affected side due to unopposed action of the affected side. So mastication muscles, right? So if one side is out, what's going to happen is that you will have the weak jaw will lead to deviates to the affected side. So that's very important. That if you have let's just keep it here. Okay, this is a face here, and you have this side, left side. Let's say this is left and this is right. You have a left side trigeminal lesion. And here, what's going to happen is, because now the mastication muscles are weak on this side, so what is going to happen is the deviation to the affected side will happen due to unopposed action of the affected side. So because these guys are weak, the other side will push towards this side, so there's going to be deviation to the affected side because we don't even have muscles here now. So that's also important, one thing. Okay, and what else you might see? And remember, the mastication is all about your opening jaw, closing jaw. Opening jaw is due to, let's just write, actually, let me close this out. Mastication, you open jaw, close jaw, right? So opening jaws are due to couple muscles. Let me just write them here. Masseter muscle, medial pterygoid muscle, and temporalis muscle. These are all opening the jaw. Now, closing jaw is only one muscle. It's called lateral pterygoid. Lateral pterygoid muscle. Okay, that's there. With the facial sensations out, meaning you will not be able to feel anything. Numb face, meaning no touch, pain, or temperature. No touch, pain, or temperature. Okay. Maxillary part would also give you which loud. Okay, one more thing, last thing here, which is right here. This dampening of the loud noises. So you will not be able to dampen the loud noise. Okay, that's there. Now, important point. How would you have? One of the important things is you can get damaged by something called trigeminal neuralgia. Trigeminal neuralgia, which is recurrent, sudden, sharp pain in the half of the face. Half of the face is just sharp, recurrent, sudden pain. Okay. Now, looking at the next cranial nerve is the abducent nerve. Abducent nerve. Well, the abducent nerve is the cranial 6. It provides LR6. So, since we talked about all of the cranial nerve to the eye, let's just put a mnemonic here. That is LR6, SO4, O3. So, lateral rectus is supplied by 6, cranial nerve 6. Superior oblique is supplied by cranial nerve 4, which is your trochlear nerve. And O3 is every other muscle of the eye. Superior rectus, inferior rectus, medial rectus, internal oblique. Everything is supplied by O3. So that's the mnemonic for all the eye muscles. So here the last eye muscle is about lateral rectus, which is doing the laterally moving the eye. So if you have lateral rectus leads to ipsilateral lesion. If there is a lesion, then it's going to cause you cannot move the eye towards the lateral side. That's going to cause two things. First thing it's going to cause is it's going to cause diplopia again. And it's going to cause, more importantly, the specific thing is going to cause is can't move the eye laterally. Can't move eye laterally. Okay. And that is going to be seen in this. When you can't move the eye laterally, so it's the eye is going to move inwards, inward eye deviation, and that is called astropia. Or esotropia, my bad. Esotropia, inward movement of the eye. And that is all for the abducent nerve. Now the major now is the facial nerve, which is CN7. Now the facial nerve here is about facial movements, eye closing through which muscle? Orbicularis oculi. Auditory volume modulation by stapedius. And the taste from the anterior two-third. So taste, somatosensation, if you look up there, somatosensation of the anterior two-third is from trigeminal, and the taste of the anterior two-third is from the facial. Through which branch? Chorda tympani. Lacrimation is there, salivation through salivation is submandibular sublingual glands or innervated by CN7. Okay. So CN7 is very important. It has the motor and the sensory supply, right? So now let's take a look at first thing, important thing is about here the dampening, yeah, the stapedius, auditory volume modulation. So auditory modulation, volume modulation by stapedius muscle, what it does is it decreases the volume. It decreases the volume by dampening the ossicle movement in the middle ear. So it dampens the ossicle movements. When you dampen the ossicle movement, they won't move, and when they don't move, there's less sound that is going to be transmitted. Okay, but what's going to happen if you have a lesion? If you have a lesion to the cranial nerve 7, now it's going to give rise to hyperacusis. Acusis, acusis, which is to indicate that it is lesion is going to be there, and it's just going to cause hyperacusis. It indicates that the origin of the lesion is close to the brainstem. And why is that? if you have hyperacusis of the facial nerve. Because now let's just go back to one more point here. That is that this auditory volume modulation, which generates the stapedius muscle, it is one of the first branches of after the origin of the cranial nerve 7. So if you get this hyperacusis in facial nerve, you will right away tell, okay, the lesion is going to be close to the origin of the brainstem where the facial nerve is arising, because as soon as it arises from the brainstem, one of the main branch it gives is to the stapedius muscle. If you knock this out, that means it's very close to the actual brainstem. The lesion is very close to the brainstem. That's important. Other than that, you will also have with this, you will think about one more thing, that is your loss of corneal reflex. Let me see here. We said here is the loss of corneal reflex will be there. That's one thing. On top of that, you have a loss of taste. Taste will be out from the anterior 2/3. Hyperacusis because of stapedial muscle paralysis. We talked about it. And patient can tolerate sounds, and there's a decrease in lacrimation, and there is going to be decrease in salivation. So this is all about this facial nerve. Okay. And now let's move on to vestibulocochlear. Vestibulocochlear nerve is the cranial nerve 8. It is about hearing and balance. So it has two portions, as the name suggests, vestibular and the cochlear. The vestibular portion of it compensates for the eye movement. It compensates the eye movements, while the cochlear portion of this is for hearing. So you have hearing and balance. Okay. So if you knock this out, if there's a lesion to the vestibulocochlear nerve, what's going to happen is, so vestibular part will give the problem like vertigo, because remember, vestibular was giving the compensation to the eye movement. So now you are just giving the vertigo, nystagmus, and imbalance, right? With the cochlear part that's all about hearing. So you will have hearing loss and tinnitus, plus tinnitus. Okay, and that's all about the cranial nerve 8. Now let's look at cranial nerve 9, which is the glossopharyngeal, CN9. Glossopharyngeal nerve, it has a special sensation for the taste and general sensation from the posterior 1/3 of the tongue. So taste and sensation. So taste is there, plus just the sensations from the posterior 1/3 of the tongue. Swallowing, it helps in swallowing, which is and also salivation. So parotid gland, if you recall, parotid gland is one of the major for salivation. So although if you knock out your facial nerve, which is salivation, submandibular and sublingual, but major salivation comes from parotid gland. So salivation, you're not gonna have a salivation problem, because salivation from parotid gland is specific from CN9. So that is gonna be present there. It also has the carotid body monitoring of carotid body, sinus, chemo and baroreceptors, elevation of the pharynx and larynx through stylopharyngeus muscle while swallowing. So while you swallow, you try to swallow right now, what's going to happen is your pharynx, there's going to be elevation of pharynx larynx, and that is to the which muscle? Stylopharyngeus muscle, and because of CN9. Okay. One more thing is it also has tympanic membrane. So posterior 2/3 and tympanic inner surface, escutcheon tube, middle ear cavity. So sensation from there. Okay, that makes sense. So one more is here. It's all about the sensation from the middle ear cavity. Tympanic membrane and inner surface, escutcheon tube, all that. Because it elevates the pharynx and everything, upper pharynx affected portion will if you affect this, there's going to be effect in the gag reflex. We talk about the lesion right now. Let's talk about lesion now, actually. So in the glossopharyngeal nerve, the lesion is one important thing with the lesion that you can test right away is the gag reflex. Absent of gag reflex. Okay, that's there. And there's also going to be the loss of taste from the posterior 1/3 of the tongue, that is in there. Loss of sensations from the upper pharynx, sensation of the upper pharynx, and also because of carotid body and the sinus chemoreceptor baroreceptors, there's going to be hemodynamically body it's going to trick into decrease in blood pressure. So when you lose this out, it's going to trick the body as if you have a low blood pressure, and that is going to cause a reflex increase in blood pressure and also increase in heart rate and vasoconstriction. So 3 things related to hemodynamic problems. And that is all for the glossopharyngeal. Then you have the last, not the last, CN10 actually. Cranial nerve 10, which is the vagus nerve. Vagus has the taste from the supraglottic region. Okay. Supraglottic region. Swallowing, soft palate elevation, midline uvula, right? Talking, cough reflex, parasympathetic to the thoracoabdominal viscera, monitoring your aortic and chemoreceptor, chemo and baroreceptor. So it's the aortic and chemoreceptor also monitors the same way as the top one, which monitors the carotid body and the sinus. Here it was in the carotid body. Here the vagus is from the aortic arch. Okay, and so this is all about vagus. Well, for the vagus, what's going to happen is when you knock out your vagus nerve, it's going to cause, first of all, it's going to cause loss of gag. Now you ask why? Loss of gag reflex, because that's the efferent fibers, and we will see how the efferent fibers are through vagus nerve, and afferent is through the CN9. Okay, and that's the efferent nerve. So loss of gag because efferent fibers through the vagus are out. Okay, that's one thing. Second thing is all about is the loss of sensation in the pharynx, because it was the sensation to the pharynx and supraglottic region, everything. So you will have loss of sensation in the pharynx and larynx, pharynx plus larynx, and also lesion. High yield at this point, that lesion, soft palate will deviate. Lesion to the side of the palate collapses, so it gets lower than the normal side. So whichever side has a problem, that will be seen as lower than the normal. So that side will be lowered as compared to the normal soft palate. That's one thing. Okay. Other than that, we also have the uvula will also deviate, and that deviation is also high yield. That it deviates away from the lesion. So it deviates away. So this guy, it's not going to be ipsilateral deviation. It's going to be deviation away from the lesion. Let's say if you have a left side lesion, it's going to deviate towards the right side, away from the side of the lesion. Also, because you're having this aortic arch, chemo and baroreceptor, so also you're going to have hemodynamic instability, in which you will also have increase in heart rate, and you will have increased heart rate and cut down of the parasympathetic nervous system, because parasympathetic comes from vagus. So when you knock this out, you're not going to have any more PNS, parasympathetic nervous system. So the dominant will become SANS. Sympathetic nervous system becomes dominant for the vagus nerve. Okay. And on top of that, it also going to high yield point is going to present with is hoarseness, dysphagia, and dysarthria. Okay. And that is all for vagus. Now we have the accessory nerve and hypoglossal. Accessory is a CN11. CN11 is about head turning, shoulders shrugging to the sternocleidomastoid muscle and trapezius muscle. So if you have a palsy, if you knock this CN11 out, cranial nerve 11 out, you can have difficulty turning the head towards the normal side. Turning the head towards the normal side. Shoulders will drop. There's going to be drop of shoulder on the affected side. Okay, and that will be seen with the CN11. Now the last is hypoglossal, CN12. It's all about tongue movement. Okay, which tongue movement is the protrusion of the tongue. Okay, now the protrusion of the tongue is through genoglossus muscle. Let me see if you can see that. So genioglossus muscle. Okay, so if there's a palsy, if you knock this out, the hypoglossal nerve, it's going to cause protrusion of the tongue on the affected side. Okay, and how can you knock this nerve out? For example, if a patient underwent carotid endarterectomy, they can lose cranial nerve 12, and that can cause the protrusion of the tongue on the affected side. And what else we might have here? And that is going to be, I guess, all for here. But let me see one more thing. That one thing here that you will see with the hypoglossal nerve is that, let me give you an example. If you have a right side nerve affected, that's going to cause the deviation of the tongue. When you try to protrude the tongue out, there's going to be deviation of tongue towards the same side, to the right side during protrusion, right? And why is that? Because the unaffected side, which is the left side in this case, that is going to force, those muscles are going to force towards this unopposed side, because there's a lesion on this side. So right side meaning right side, so ipsilateral loss will be there basically, okay? And yeah, that will be all for cranial nerves. All right, now let's talk about cranial nerve reflexes. Although they look like they're not important, but they are super high yield. Okay, let's talk about them. And the way I'm going to tell you is going to be super easy. All right, so let's talk about the first thing we're going to look at is pupillary reflex. We're going to start from bottom, okay? Pupillary reflex is all about, and now we're going to combine a couple things together. Pupillary and accommodation. Combine these two together. Now, why am I combining these? Because if you look at the afferent and efferent, they're the same. So why couldn't we say pupillary / accommodation is CN2 and CN3? Who's coming in? Coming in is the 2. Who's going out? We're just adding one number. Add one number. +1 US code +1, right? That's what we're going to do. We're going to +1. CN3 is going out. So pupillary and accommodation, you can call it APPA, whatever you want to call it, but both of them are coming in from the initial standpoint of view. You're looking at cranial 2 is coming in, 3 is going out. Just adding one number. Okay, changing color here. Now the second one is going, the third one actually, 1, 2 is done. Now the third one and the fourth one is going to be lacrimation and the corneal reflex. So 3 and 4. So what is this? If you look at the afferent is going to be cranial nerve 5. What is going as an efferent, as an out, is cranial nerve 7 and cranial nerve 7. Same, right? But how do we know? Now, the important thing is the first one was easy, right? We could say, let's actually, I I have to add one more thing here. For how do we know cranial nerve 2 is the for accommodation? If you look at two C's, call it 2. Okay, or if you look at the pupillary, it is 2. So these are the only things here which has 2 alphabets in a one thing. So that's going to be your afferent. So CN2, accommodation CN2, cranial nerve 2 is the afferent. If whatever is the afferent, you just got to +1, add 1, US area code, add 1 to it, man. What you're going to leave is CN2 is coming in, what's going out is CN3. It's like upgrade, you're upgrading that thing. Whatever is coming in, you're giving out one more, right? Afferent and efferent. Afferent is coming in, and efferent is going out. Okay, that is there. With the lacrimation and the corneal, now how we doing is 5. We need to know what is coming in, right? So the coming in is going to be the 5. If you look at C is like 5, right? C is like 5. In the lacrimation also, C is like 5. But the corneal, if you know corneal, you would right on know the lacrimation as well, because they're the same. So C is 5, so 5, cranial C and 5, 1. And again, same thing, CNY 5, 1, which is the ophthalmic branch here, because it's a corneal reflex. And for the lacrimation is the loss of reflex does not preclude emotional tears. Well, what is going out is the 7. So here, because now this is, I guess this is the only one where we are doing adding 2 things here now. So coming in is 5, going out is 7. Just bear in mind right now, and we will, once we're done with the whole thing, things will be very simple. Now you're left with jaw, gag, and cough, right? So now let's look at, we can look at, let's say, jaw. Now the jaw, although it looks very, hey, who's going to remember jaw? Who's going to see jaw? But jaw is high yield, okay? Everything is high yield in this table. So jaw jerk. What is jaw jerk doing? Look at the W here. W, right? So it's like a V, right? V, right? So V3, so V3, okay? That's the jaw jerk. So if the V3 is coming in, with these ones, the good point is, with the jaw and the cough, whatever is coming in is going out. We're not adding 1, we're not subtracting 1. Whatever is coming in is going out. V3 is the afferent, V3 is the efferent. V3 coming in is the sensory with the muscle spinal from masseter muscle, and the motor masseter muscle is just going out with a jaw jerk. For the gag reflex, now let's change color. The gag is, if you look at the gag, instead of saying a gag is like a 9, right? So 9 is going to come in. And what was the whole thing about the cranial nerve? We got to add 1 to them, man. They're the guests. We got to give them one more thing. So add +1. So here's what you have is the 10 is going out. Exception was only one thing. For the for the corneal, or with the same thing as lacrimal, it's not just adding 1, it's actually adding 2. Because we're like, hey, corneal lacrimation, emotional guy is coming in, emotional. Yeah, you're showing me some emotions. I am going to give you 2. Normally, a guest comes in, I'm going to give 1. But hey, they're crying all over the place. So give them 2. For the corneal and emotional, you are giving them 2. Let's say 2 donuts, whatever. I mean, you call it, okay? The last one here is about cough. Okay, now let's change the color to cough. Now the cough is also very easy. How's the cough easy? Because the cough is going to be 10. So 10. So see 10, 1, 0. So O for 10. But the cough, you just know, okay, cough, you can say, okay, corneal is also, O is also there. Something you just have to memorize. So cough, just remember on top of your head, cough is 10. When somebody is coughing, that's 10 by 10. He's getting 10 by 10. 10 is coming in and 10 is going out. Also phrenic and spinal nerves. Okay. So yes. So yeah, you can call it either that, or you can also say younger person comes in. and older goes out. OLDER goes out. Coming in comes in when I say that's the afferent, and going out is the efferent. So a younger person, meaning whatever you're getting in afferent is going to be younger, meaning a lower number, and whatever is going out is going to be a higher number, and so older a number. With that in mind, let's just recall the whole thing and move on to the next. Okay, so we are going to join two things together here. We have the accommodation and the pupillary. What is accommodation? It has two C's, it has two L's. So two is coming in. What is going out? The general rule is younger coming in, older going out. So 2 is coming in, 3 will be out. Okay. Now there's the next one, changing color here. We have the corneal and the lacrimal. Because they're emotional, we are going to have them an additional numbering, meaning this is like 5 is coming in, right? 5 is coming in, and 7 is going out. 7 will be going out. Okay, now you're left with jaw. The jaw, let me change color for the jaw. The jaw jerk is going to be, again, just think about W as a V, right? So V again, you have a fifth one coming in, and fifth is going to go out. This is exception. Jaw has an exception. Not only jaw has an exception, but the cough also has an exception. So if jaw is fifth, the cough is going to be higher, right? It's going to be 10. 10 is going in for the afferent. 10 will be coming out as an efferent. For the gag is super easy because it's, as the G is 9. I mean, you can literally see that at 9, right? So 9 is coming in. The simple rule, you have to give 1, which is 10 going out. So 9 and 10. So just got to know that, and that's all for the cranial reflexes. Moving on with the next one, it's called mastication muscle. We did touch on it, but let's just quickly go through it. 3 muscles close the jaw: masseter, temporalis, medial pterygoid, which is amant. But the only one muscle is protruding the jaw, which is lateral pterygoid. All are innervated by the mandibular branch of the trigeminal nerve, CN3. CN3 is innervating everything. Okay, so if you look at the muscle temporalis, masseter, so big muscle, look at that, masseter, temporalis, masseter, and medial pterygoid, only against one muscle, which is lateral pterygoid. Wow. Okay, moving on with the spinal nerves. Spinal nerves, there are 31 pairs of spinal nerves: 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. Nerves C1, C7 exits above the corresponding vertebra. C3 exits above the third cervical vertebra, while the CN8 exits below C7 and above T1. So that now CN8 is exiting below C7 and above T1. Okay, so the mnemonic here is 7 up are all above, and below that is all below. For example, so let me just put 7 up. You know it's 7 up, right? Like Coke 7 up, something like that. So 7 up. Everything above 7 is up, and everything below this point, CN8 and everything else, is just going to be below. Okay. Why not? Why is that? As we don't have CN8 vertebra. Because we lack CN8 vertebra, okay? That is why. So if I was to draw you a picture, I could say 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 6, 7. Okay, 7. So everybody's what? 7 and up. So they're saying, okay, so you have C1, C2, C3, C4, C5, C6, C7, and there is no C8. There is no C8. When there is no C8, so you have a cranial nerve 1, I mean not cranial nerve, but here spinal nerve 1 going up top from it, 2, 3, 4, 5, 6, 7, right? And for the cranial nerve, not cranial nerve again, spinal nerve, 8, it has to go above T1 and below C8. So the mnemonic here is 7 up. Everything above 7 will be going up. Everything below 7 will be going 8. Why is that? Because there is no C8 vertebral body. There is no C8 vertebral body. Okay, and it just starts after C7. All you have is T1. So let me do this. After C7, you have just the T1, T2, T3, and all that. Okay. All right. So all the other nerve exits L2 below the second lumbar vertebra. All right, that's good. Let's move on to the next, which is called spinal cord lower extent, high yield. Here, what do we have? In adults, spinal cord ends at the lower border of the L1 and L2 vertebra. So looking at L1 and L2, this is L1. Look at the spinal cord. It is ending. They're saying at the lower border of L1 and L2. So here it's ending, right? Subarachnoid space, which contains the CSF, right? It extends to the lower border of S2 vertebra. It extends where till where? To the lower border of S2. Whoa, this is S2. So subarachnoid space, it is extending till S2. Amazing, right? Lumbar puncture is usually performed between L3 to L4 or L4 to L5. So all the way from L3 to L5 can happen anywhere. Okay. Level of the quadra equina. So this all is quadra equina. Okay, to obtain the sample of CSF via widening the spinal cord. To keep the cord alive, keep the spinal needle between L3 and L5. A very good mnemonic. Now, the important thing is this. Needle will pass through the skin. The first thing it's going to pass is the skin, the fascia and the fat, the supraspinous ligament, the infraspinous ligament, and importantly, the ligamentum flavum. Ligamentum flavum, at this point, when you're going through it, you will feel resistance at this point when you're trying to go down through the spinal needle. You will feel resistance at this point. Feel resistance. Okay, feel the resistance. And you have this epidural space. What is an epidural space? Epidural space is the epidural anesthesia stops here because it is above dura. Remember, recall the whole thing. You have a pad, PAD, and this is your spinal cord or the brain. So it is PI is attached. Then you have the arachnoid, and then your dura. So epidural is right here, like above the dura, right? So epidural anesthesia doesn't even cross the dura. It is just above the dura even. Okay. Then you have the dura mater. You cross dura mater. Then you cross the arachnoid. So you're crossing dura, crossing arachnoid. Remember, right here. Okay, where did it go? PAD. So you're crossing everything and crossing all the way till here. And here is your fluid, CSF. Between what? Between P and A. Between P and A, you got the fluid. That fluid is CSF. You never cross the pia mater, and you never mess up with the spinal cord tissue itself. All you are crossing is arachnoid and the dura mater to reach to CSF. Okay, that's called the subarachnoid space. CSF collection occurs here. Okay. An important point that I've just mentioned is the pia mater. You never there is no piercing of the pia mater in the taking out the CSF. Okay. What else we might see now after this quadra equina? We have the phylum terminale there. Okay, that's also there. Now, one important point for the needle is we said we have to put it through L3 to L5, but anatomically to locate it, locate the iliac crest and insert needle at that level. So what you want to do anatomically is you locate the anatomically you locate what? The iliac crest. Iliac crest. And insert needle at that level. So you locate iliac crest, you go all the way at the back, and you insert the needle. And that's going to be where? That's going to be L3 to L5. Somewhere around that point. Okay, now important point, one more thing is, we talked about adults, but not the children, right? So the children, we have the spinal cord ends at which level? At little, I think at level higher level than this. So I should have mentioned something, but I haven't. Okay, nice. But okay, let me just recall the whole thing and move on with the next point. So the children they have the spinal cord ending at the lower surface. So from L2 to L3. L2 to L3 in children. So you want to do for the children is L4, but here's the way: L3, L4, L4, L5. Children lower is better, and that is going to be all. Let's look at the things here. What are the ligaments? So you have the anterior longitudinal ligament, posterior longitudinal. So you have one ligament here that's called anterior longitudinal, then you have a ligament right there. It's called the posterior longitudinal, and then you have what? Then you have where's the ligamentum flavum? Let's take a look at that. Ligamentum flavum, not seen here. Okay, I don't know if it's there or not, but let me double check. All right, so ligamentum flavum is going to be, you'll feel resistance at that point. That's a very high yield point, and then and yeah, that's pretty much it. So let's just recall the whole thing, and we should look for the quad equina syndrome and all that. So recalling the whole thing or summarizing, simple thing: in adults, the spinal cord ends at L2 and L1 to L2 level, but for the neonates or infants, the spinal cord ends little down. That is going to be L2 to L3. So for the kids, you want to do L4 to L5, but for the adults you can go from anywhere from L3 to L5. The mnemonic is very good. Lumbar puncture can to keep the cord alive, keep the spinal tab between L3 and 5. This spinal tab, it is the area anatomically the iliac crest is there, so you can anatomically feel the iliac crest, and then at that landmark locate the site for needle insertion, and then insert the needle. Go for that, right? And then you have you will pass the skin, the fat, the ligaments. The ligament flavum will give you the resistance. Then the epidural space, in which you're not piercing anything, it's above the dura. And then once you cross the epidural space, then the dura is going to be you are crossing the dura mater, the arachnoid, and this is the CSF right there between the pia and the arachnoid, but you're not crossing is the pia mater. That's high yield. Okay, other than that, let's talk about one more thing here. That is going to be this this conus medullaris and cona equina. So conus medullaris is the branches into the spinal nerves forming. So conus medullaris is what is it? It's the branching. It's basically it's basically branches. Spinal cord branches into spinal nerves forming cauda equina. Okay, now there are two simple things here. That is something called as right here, conus medullaris and cauda equina syndrome. They are rare neurological emergencies caused by compression, which is compression due to either disc herniation, tumor, or trauma of the terminal end of the spinal cord. Of the end, if you're looking at the terminal end of the spinal cord, remember it's not branches right now. It's just the terminal end of the spinal cord. That's called conus medullaris. And when this branches off in small spinal nerves, that's going to be called cauda equina. So conus medullaris and cauda equina, okay? Two different things, and you know what they are now. Or the lumbosacral spinal nerve roots, which is because now you're looking at lumbosacral spinal nerve roots, you call it quada equina. Okay. Now these guys are going to present with radicular low back pain, subtle perianal anesthesia, bladder bowel dysfunction, and lower limb weakness. Leads to symmetrical with upper motor neuron signs like spastic upper motor neuron sign in the conus medullaris, asymmetrical with lower motor flaccid paralysis sign in the quada equina. That's the differentiation features. So let's recall some more things here, add on some more things. For the conus medullaris syndrome, the lesion at L2 till L2 or something will lead to sinus symptoms. So if you look there, the spinal cord ends at L2, right? And that is exactly what we're saying. If you have a lesion at L2, it's going to give you conus medullaris syndrome sign and symptoms, which is again upper motor neuron sign symptoms, which will give you flaccid, which will give you what? Spastic paralysis of the bladder / rectum, right? Impotence will be there. Saddle anesthesia of the nerve roots S3 all the way to S5. Saddle anesthesia will be there. And the causes are all of these: disorientation, trauma, tumor, anything. While versus the next one was about conus medullaris and quada equina. Quada equina, on the other hand, it causes, when there's a compression of greater than 2 of the spinal roots, it's called the syndrome, which is the quada equina syndrome. And damage leads to lower back pain, which causes radiation pain radiation to the both legs. Again, you will have saddle anesthesia, which you already had there. Bowel and bladder dysfunction will be seen, and loss of ankle jerk and weakness of the plantar flexors. So loss of ankle jerk is also important. So loss of ankle jerk is going to be seen with the quada equina. So let's just recall this and move on with the next. So we talked about this, that the conus medullaris, when the spinal cord ends, it's called the conus medullaris, and this conus medullaris branches into spinal nerves. You can see them here. If they're small spinal nerve that they're branching into, and these spinal nerves, now when they are formed, they are called quada equina. Okay, and with this, you can just think about high yield point is this, with all of them, both of them will have back pain, saddle or perianal anesthesia, bladder bowel dysfunction, and lower limb weakness. But with the conus medullaris, you're going to have a symmetrical with an upper motor neuron sign, and with quada equina, you're going to have asymmetrical with lower motor neuron signs. And lower motor neuron sign of flaccid paralysis, upper motor neuron sign is spastic paralysis. And that is all for this. Moving on with the next one. All right, now let's take a look at spinal cord levels and associated tracts. All right, what do we have? We have legs for the lumbosacral, lateral in the lateral corticospinal tract, spinal thalamic tract, dorsal column are organized as you are, with the hands on side, arms outside, legs inside. Let me just draw that. So let's take a look at this picture first. So we have a cervical, thoracic, and lumbosacral spinal cord levels, right? So here all we have is, at the very back we have the dorsal column, 2 dorsal columns, right? But by the lumbosacral, you only have 1 dorsal column. Okay, and look at the ventral. Ventral means anterior horn, so this is anterior. Lateral is lateral, and you know lateral is there. And lateral is seen in where? It is seen in the thoracic part. Thoracic, thoracic spinal cord level. At the thoracic spinal cord level, we're seeing lateral horns. Okay, and we have a white matter and gray matter. White matter is white and gray is gray. Okay. Now let me see if they have actual picture in which they define. Okay, they don't have it. Great. Okay, looking at this one, what we really need is let's just take a look at this. Dorsal column are organized, how they're organized, okay? So hands on side, let's just do this. Hands on side, arms outside and legs inside. Arms are outside and legs are inside. So medial are the legs and lateral are the arms. Lateral, medial. But we will take a look at that later on as we go. So let's just draw this quickly and figure out what we said. Okay, so here all we have this whole thing. This is like a rough, where did I draw the rough in? And okay, so here all we have is dorsal column, yeah, dorsal column, and after the dorsal column, we have this lateral spinothalamic, which is at the lateral side called lateral. Oh my bad, not spinothalamic, corticospinal. Then you have this above here is the lateral spinothalamic, and anteriorly we have it's called anterior spinothalamic and anterior corticospinal tract. These are all the tract anatomical location, okay, of all the tracts. So now let's take a look at next page where we will actually see how things are going. So spinal tract anatomy and function, high yield. What we have is spinothalamic tract and dorsal column as they are the ascending tracts. So they are saying spinothalamic tract and dorsal column are ascending tracts. So I'm going to give them a color, while the other color is going to be given to the corticospinal tract, which is a descending tract. And the important feature for the descending tract is they would cross and then synapse, as compared with the ascending tracts, which would synapse and then cross. Okay. They would cross and synapse. So let's just take a look at each one of them. Let's take a look at the first one, which is the spinothalamic tract and the dorsal column. For the spinothalamic tract and the dorsal column, what do we see? So spinothalamic, the function is pain and temperature. For dorsal column is the pressure, the vibration, the fine touch, the proprioception, the conscious proprioception. First order neuron, high yield. First order neurons are going to be sensory nerve ending, the A delta and C fibers of the pseudo unipolar neurons in the dorsal root ganglia, which enters the spinal cord. So let's take a look at this first track. It's a first order neuron. So first order neuron is coming from all the way from A delta and C fibers. So I guess delta is like this and C fibers. All the way to the dorsal cord, through the dorsal root ganglia, which is right there, dorsal root ganglia, all the way into the spinal cord. So it enters the spinal cord at that level. That's the first synapse, first order neurons. It synapses in the posterior horn, which is the spinal cord. So it is synapsing right here, which is the posterior horn. After synapsing, the second order neuron decassates. So this is very high yield, that it is decassating at the level it enters. It decassates in the spinal cord as the anterior wide commissure and is sent contralaterally. So at the level it enters and it decassates right away at the anterior wide commissure and then ascends upwards, right? Contralaterally now because it's decassated. Now the second synapse is going to be in the VPL of the thalamus, ventroposterior lateral thalamus, right? And then from there, the third order neuron will project to the primary somatosensory cortex. Okay. And remember, for the thalamus, all sensations except smell goes through thalamus. So that's one thing, right? So now looking at the second one, which is the dorsal column, the first one is sensory, the first order neuron, or from the sensory nerve ending of the pseudo unipolar neurons in the dorsal root ganglia, which enters the spinal cord, is sent ipsilaterally in the dorsal column. So it's just going ipsilaterally. It's not decassating at the level it enters. So if you take a look here, what I meant to say is, look at this. It's coming from all from the, again, to the dorsal root ganglia, but it is just in the dorsal column, which is here. It is just going up till the level of medulla, and at the level of medulla is going to decassate. So decassation of the medial limb meniscus. So let's read the decassation now. So now the first synapse is going to be from at the level of nucleus gracilis and nucleus cutaneus ipsilaterally, right? Ipsilaterally medulla decassates in. Now if you look here, we said it is going to decassate at this point of medulla. So decassates in medulla leads to ascends contralaterally as medial limb meniscus. So as soon as decassates, it's now called medial limb meniscus. Well, actually decassates at, it says ascend contralaterally as medial limb meniscus, right? And again, it goes to the VPL again right there, and to the primary somatosensory cortex, right? So the mnemonic we have for the dorsal column is going to be feeling very patient. Feeling very patient. Feeling very patient is all about fine touch. Very is vibration. P for proprioception and pressure. So because this one is feeling very patient, this patient is very patient. I mean, this dorsal column is very patient. So it's going to wait. It's going to wait until the medulla to decassate. It's going to wait till medulla to decassate. Okay. Now, in contrast that with the spinothalamic tract, which we have the mnemonic that is not that patient, not that patient. So not that patient, we can say it is the non-discriminative touch. That's one thing, not that patient. And then for not, wait, let me just write that again, not that patient. P is for pain again, and T is for temperature, and for not that patient. And because they are not that patient, the spinothalamic is not that patient, they will decassate right at the level they enter the spinal cord. Decassate right at the anterior commissure. That's important, okay? Now looking at again the dorsal column, we talked about decassation, how they're different. On top of that, so nucleus gracilis and nucleus cutaneus ipsilaterally medulla, what does that mean? So from the upper limb and the lower limb, right? So cutaneous fasciculus are going to be seen in the so gracilis gracilis fasciculus is going to be seen from the very bottom, meaning because it's again it's a lower limb which goes through the gracilis fasciculus, and the upper limb goes through the cutaneous. So how are you going to remember that? Well, C comes before G. C comes before G, right? Like A, B, C, D, E, F, G, right? So C is before. So upper limb is through this nucleus cutaneous, and lower limb is going to be through nucleus gracilis. Okay, C comes before G. That's the mnemonic. Okay, now important point was decassation. Important point what goes through gracilis and cutaneous, and that's pretty much what we have for these two. The last one is all about, let's change color here, is all about spine, the corticospinal, from the cortex to spine. So it's the voluntary movement. So the muscle movement now. Now the voluntary muscle movement. So here's a simple thing. So the upper motor neuron is coming from the primary motor cortex, is going to descend ipsilaterally through the posterior limb of the internal capsule and cerebellar peduncle. It decussates. Where does it decussate? At the medulla, at the caudal medulla, which is pyramidal decussation, and descends contralaterally because it decussates now is contralateral, right? Synapses the anterior horn to the spinal cord. And the second neuron will leave the spinal cord, and it will synapse at the neuromuscular junction at the skeletal muscle. Again, the decussation of this thing is again in the medulla. Let me highlight that part. Decussation at the medulla. Let's take a look at the picture now. So it starts at the primary motor cortex, goes through the posterior part of the internal capsule, goes through the cerebral peduncle, and in the medulla it decussates. When it decussates, it goes in that same synapse, the first order neuron is going to the anterior horn. At the level of anterior horn is going to synapse with the second order neuron. So there are only two order neurons in the voluntary muscle control from the cortex to spine. So again, as the name suggests, corticospinal, from cortex to spine. That's it. So only two things. From cortex to spine. Corticospinal, what are they doing? They are doing the muscle, giving the muscle, right? Voluntary muscle control. So from here, it is just going to make a second order neuron, and that second order neuron from the anterior horn will go to the neuromuscular junction and cause the muscle movement. Okay, and if you have a lesion of this thing, it's going to give you upper motor neuron. So all the, okay, one high yield point, let's just discuss that here as well. So till this point, anywhere above the lesion, for example, till this point, all you have is all this first order neuron, right? First order neuron. And the second order neuron is this one. So if you knock out your first order neuron at any point, it could be in the spine, it could be in the peduncle, it could be in the internal capsule, it could be in the motor cortex. Anything from the brain all the way to spine until it comes out of the spine is going to give you an upper motor neuron lesion. Signs, symptoms. And once it's out of the spinal cord, that's going to be your lower motor neuron. So if you knock this thing out, it's going to give you lower motor neuron lesion signs, symptoms. Okay. And that is what we have all the way. So let's just recall the whole thing, and that's it. So it's very easy, very, very easy. All you gotta know is the mnemonic. That mnemonic is spinothalamic tract is not that patient, meaning it's going to decussate right away at the anterior commissure, right at that point, at the point it enters, and it is not that patient. So T for temperature, P for patient. Dorsal column, on the other hand, is going to be feeling very patient. Feeling very patient, meaning fine touch. Very means vibration. Patient means pressure and proprioception. And because it is very patient, so it's going to decussate at the level of medulla. It's going to wait till the medulla, and it's going to decussate at that point. And for the voluntary muscle, which is corticospinal, as the name suggests, from the cortex all the way to spine, you have only two neurons: upper motor neuron, lower motor neuron, and that is for the and they will also decussate at the level of the medulla. Okay, same as dorsal column. And that is all for tracks. Now, moving on with the cranial reflexes, it's again super easy peasy, right? And what this is, it's the way you're going to remember this is simple. And that is, if you look at the bold part, they're saying, okay, reflexes count up in order. Main nerve root is in bold. So just remember the bold, the rest will follow. So what you're going to do is, so you're going to have alphabetical, not alphabetically, but in a numerical order. And that is your S1, 2, okay, 3, 4, 5, 6, 7, 8. Easy, right? Simple. 1, 2, 3, 4, 5, 6, 7, 8. No rocket science about it. So all you're gonna know now is, so you know that you have cervical, you have lumbar, and you have sacral nerve roots, right? So that's it. So cervical, lumbar, and sacral, lumbar, and cervical. Now let's talk about the actual reflexes. So for the for the sacral, the reflex we have is the ankle reflex. For the lumbar, we have the knee. So just think about it. You have the ankle, then you get the knee, and after the knee, what you're gonna think about the arm, right? In the arm, you have two. What is two? You have the tricep and a bicep. So tricep and bicep. And these are all the reflexes. If somebody says, okay, what is the knee reflex? Is going to be L3, L3, and L4. Okay, one more thing, adding onto it, that's going to be cremasteric reflex and anal wing reflex. That's also here. S3 and S4 are going right here. Anal reflex is S3, S4. Cremasteric reflex is going to be L1 and L2. But how are you going to recall all this? So you're going to say, okay, let me change color here. You can say S, or you could just remember that one, or just say, okay, S4 is going to be anal reflex. Anal wing, my bad. Anal wing. And L1 is going to be for the cremasteric. But even if you just remember anal and cremasteric through that, this is super easy. So let's just recall this. Let's actually read the first bit and then we recall the whole thing. So Achilles reflex, S1 and S2. What was Achilles reflex? Ankle reflex, right? S1 and S2. Patellar reflex, that's the knee reflex. Patellar, L2 and L4. Now you say, hey, you don't have to, because look at the bold one. All we are looking at is the bold. The bold is the main nerve root. They got to mention the bold one. If they don't mention the bold one, that's nothing, right? So they have to mention the bold one. That's why the bold are important. Here, S1. Here, S1. Here for the knee, L4. Right there is L4. You see? That's what I'm talking about. I mean, you also have a mnemonic here. Buckle my shoe, kick the door, pick up the stakes, lay them straight. But, I mean, yeah, sure. Why not? That's the mnemonic for the reflexes, but it doesn't tell you the nerve root. So these are the nerve roots, right? Then you have the biceps and biceps and brachioradialis, which is C5, which is the main. So C5 is main there. And then the next is the tricep, which is C7 is the main. So C7 is the main in the tricep reflex. Lay them straight. Additional reflexes, high yield. I mean, they're not like to cremasteric, L1, L2, anal, wink, S3 and S4, wink the glower, testicular move, all that. Reflex grading. 0 is absent. 0 is absent. 2 is normal. 2 is normal. Everything above, anything below 2 is going to be hypoactive. Right, hypoactive. And anything above 2 is going to be hyperactive. So hypoactive is going to be seen in what? Is it seen in upper motor neuron lesion or lower motor neuron lesion? It's lower, right? Because you are decreasing the number, lowering the number, meaning lower motor neuron lesion. Increasing the number is upper motor neuron lesion. Simple. Make life easy. Okay. Hyperactive is also known as brisk. You know, sometimes they say brisk reflex. You're like, hey, what is brisk? Is it low or high? It's hyperactive, brisk. Clonus, okay. You know, and that is all we have. So let's just recall the whole thing and move on to the next. All we have for the reflexes is going to be, why is it not doing this? Okay. All we have for the reflexes is going to be, change color here. Okay. All we have is S1, 2, 3, 4, 5, 6, 7, 8. So this is L and this is C. In C, you have the tricep and you have the bicep. And you have this is patellar or knee, and this is going to be your ankle, which is Achilles. Okay, here you just have S4 and L1 for cremasteric and anal wink. Anything above is going to be lower number, meaning lower motor neuron lesion. Will have this absent or hypoactive reflex. With the anything in a higher number, 2 is normal, right? So anything higher than that is going to be upper motor neuron lesion, right? You will see hyperactive and clonus in that. And that is all for the reflexes. Now let's look at the primitive reflexes quickly. Primitive are the CNS reflexes that are present in healthy infants but are absent neurologically intact adults. So infants have them, but adult would not have them, right? Normally they will disappear when within the 1 year of life. So primitive reflexes will disappear by 1 year of life. These primitive reflexes are inhibited by mature developmental of the frontal lobe. Frontal lobe, we talked about it like 10 times now. Frontal lobe primitive reflexes, right? They may reemerge in adults following frontal lobe lesion that leads to loss of inhibition of these reflexes, right? When you have a frontal lobe lesion, you cannot inhibit these reflexes, so primitive reflexes come back. Okay, what are these reflexes? Motor reflex, hang on for life reflex, what is basically abduct or extend the arms when startled and then draw together. Startle reflex, okay? Hang on to life reflex. Basically, you get a kid, you try to hold them high and they drop them, and they will go into this reflex as if they're startling. They're trying to hang on for life to something so they don't go in trauma or something. That's the motor reflex. Rooting reflex, movement of the head towards one side of cheek or mouth is stroked for nipple seeking. This is again for the child. Nipple seeking. They touch the nipple, it goes towards that side to suck that nipple. Sucking reflex, sucking response when the roof of the mouth is touched. You touch the child roof of the mouth, floor of the mouth up top, it's going to start sucking. That's the sucking reflex. Palmar reflex is the curling of fingers, the palm is stroke. As soon as this is the palm, you stroke the palm, what's going to happen is the fingers are going to curl up back. So there's a curling of the fingers, like they will draw the fingers back as to hold them, okay? Hold whatever is in the palm. Then you have the plantar reflex, which is the dorsiflexion of the large toe, fanning of the other toes with the plantar stimulation. Babinski sign, which is basically the presence of this reflex in adult, which may signify upper motor neuron lesion. Now, important thing here is normal the big toe. So here's the plantar. So normally, what the big toe wants? Normally, the big toe wants to look down to see who's tickling it, right? That's like mnemonic now. So normally the big toe wants to see down to see who's tickling it, and that's called plantar flexion. Plantar flexion. That's normal. But in child they're doing dorsiflexion. In child they're doing dorsiflexion, which is of the large toe, which is fanning of the toe with the plantar stimulation. Babinski sign is the presence of this reflex, which is dorsiflexion, in adults, which may signify upper motor neuron lesion. So again, in adults, what is normal? Normal is plantar flexion, meaning you tickle the toe. The toe, you're an adult, right? So the toe is like, hey, what's messing with you? Let me double check what's going on. So it's gonna look down. It's gonna look down, right? The big toe wants to look down to see who's tickling it. Simple. That's called plantar flexion. Right? So normal adults, you will have downward placement of the big toe, which is called plantar flexion. But if you have an upper motor neuron lesion and you're an adult with an upper motor neuron lesion, what's going to happen is that you will have dorsiflexion. You will see a dorsiflexion, okay? And dorsiflexion is when it is fanning out, it goes up. Instead of going down, it is upward movement. Okay. And that is what we have. So when you have the upper motor neuron, normally the upper motor neuron would suppress. Upper motor neuron would normally suppress the dorsiflexion, this upward movement, right? Upward movement of the big toe, which is called as dorsiflexion. So normal, the upper motor neuron will suppress this. But if you have a lesion of the upper motor neuron, it would not suppress it, and it will go down, which is dorsiflexion. Okay, again, let me just repeat this with the wording. Plantar flexion, meaning you are going down. Dorsiflexion is upward movement. Plantar means, okay, if you think about the palms and soles, if you think about plantar flexion meaning going down, plantar flexion. Dorsi is going up, man. Dorsiflexion, dorsum, posterior, upwards. Okay, that's the other way you can think about it. Or you can just say, okay, the big toe wants to look at down, who's messing with it. That's only seen in adults. A child wouldn't see that. A child doesn't know nothing, right? So he wouldn't, or she wouldn't be able to do that. So for the kids, it's normal to have a plantar reflex, have a dorsiflexion. But with adult, you're not going to have a dorsiflexion unless you have a upper motor neuron lesion. Now the gallant reflex. What is gallant? Well, gallant is stroking along one side of the spine, while newborn is in ventral suspension, which is face down, causing lateral flexion of the lower body towards stimulated side. So here's a child. Let's put a child here. Child is just laying down. This is the ventral surface, like on the back side. Stroke along one side of the spine, so you stroke on this side. What is going to happen? The lateral flexion of the lower body, so you of the towards the stimulated side. So the body will flex to this side because you are stroking that side. That's called gallant reflex. Now let's talk about the dermatomes. Dermatomes. Okay. The important thing in dermatomes are going to be, okay, C2 is the C2 has the posterior half of the skull. C3 high turtleneck shirt. Important thing is C3, C4, 5 keeps the diaphragm alive by the phrenic nerve. Phrenic nerve is important, high yield. Phrenic nerve can get damaged. This phrenic nerve can get damaged via ablation of the right atrium. When you ablate the right atrium, it can lead to damage to the phrenic nerve, which can lead to hemidiaphragm. So whichever side, it's going to cause hemidiaphragm, and the elevation, let's say if it's on the right side, so right side of the half of the diaphragm, which is called hemidiaphragm, would be elevated. So what the affected side will get elevated. That is high yield point. Okay. You can also give something called interscalene nerve block, which can block the C3 to C5 phrenic nerve, and it can also cause ipsilateral diaphragm paralysis, which it can cause hemidiaphragm. Okay, C4 is lower shirt, and all of this it's pretty simple, so I don't need to explain all this. But a high yield image to look at is this one right there. But important thing is C6 is thumbs up sign, which is like 6. Okay, look at 6. Okay, 4, and then T4 is T4 at the T4. T7 is 7 letters in Z4. T10 a point to refer pain and early appendicitis. T10, right? L1 is inguinal ligament. L4 include the kneecaps down all fours. S3, S4, S2, S3, and S4 are the S2, 3, 4 keep the penis off the floor. That's also high yield. So high yield points are going to be C3, 4 for the phrenic nerve. S2, 3, 4 keeps the penis off the floor. And you can take a look at this picture, and pretty much that is all for neuroanatomy.